All right. Can everybody hear me? Yes? No?
I can.
All right, cool. All right, since I don't know who all is on the stream, I'll just give you guys like a formal introduction. My name's Kyle. I am a paramedic here at Morgan County. So if I haven't met any of you guys, welcome. Glad to have you. Paramedic supervisor. I apologize. So we're going to be going through a cardiovascular lecture this evening that I prepared for you guys. So can you guys see my screen? Or just the camera? You guys see a little heart beating? Yes.
We have 4 chats too.
Oh, that must be good. As soon as I know that you guys can actually see the PowerPoint, then we'll get started.
You're good.
Okay, cool. So we're going to go ahead and get started. So first thing we're going to do is get into the anatomy and physiology of the heart. So we all know the different chambers, the great vessels that supply the heart, the whole am I right thing, little joke, ha 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 ha. But what about all the other structures that are a part of the heart that contribute to the form and function, right? We need to know more than just the chambers and the great vessels. So first we're going to get into connecting structures. First one's going to be the tricuspid valve. I like to think of these valves as trap doors. You can see them highlighted here on the right side of the screen. That little blue highlight is the leaflet for the tricuspid valve. Tricuspid meaning 3 cusps or points. That's where it got its name. I know it's probably really hard to imagine that that's where it came from, but that's where it did. It's got 3 different leaflets. It's got the anterior, posterior, and septal leaflets. Everything is obviously in relation to the patient's body and what's anterior and posterior. So that's where the names for those leaflets come from. It's located in between the right atrium and the right ventricle. We know that. And it's going to be open during ventricular diastole and closed during ventricular systole. Okay. So for ventricular diastole, what is that, guys? Those of you that are in the room. Sorry for those of you online. I wish that I could ask you questions.
When your heart relaxes,
When the ventricle relaxes is diastole, right? So then by that same token, then what would be ventricular systole?
When there's a load behind.
Okay, so if the tricuspid valve is going to be open during ventricular diastole and closed during ventricular systole, what's happening when that's opening and closing? Yeah, so the heart is going to be pumping and then relaxing. At what point is the blood going through the tricuspid valve? It's going through the tricuspid valve during diastolic phase so that that ventricle can fill, right? And then right before the ventricle contracts, it needs to close so that it pumps the blood back out through the pulmonic valve and not back up through the valve into the atria where it just came from, right? That's exactly what its goal is to prevent the regurgitation back into the right atrium during systole. It attaches directly to the chordae tendineae, which we're going to talk about here in a second. Next structure in the right ventricle is going to be the moderator band. How many people have even heard of the moderator band? Yeah, this is where anatomy and physiology classes typically fail you. A lot of times what they'll just focus on the main structures and stuff you absolutely have to know. But when it comes to the smaller, more subtle microanatomy of the heart, there's a lot of things that are left out that I think are really fascinating on how the heart actually functions. So the moderator band, I like to think of it as an electrical bridge. It's originally thought to moderate, hence the name, the expansion of the right ventricle during diastole. So originally we thought that what it was there for was to stop the right ventricle from over expanding during diastole, overfilling, so to speak. And to a degree, it does kind of play that role. But more importantly, what it's actually used for, and we'll get to it here in a second, it's also known as the septomarginal trabecula. All those little nooks and crannies inside the ventricles that you can see that stop the ventricular surface from being smooth, those are called trabeculae. So this is called the septomarginal trabecula. Everybody follow me so far? All right. This actually carries a significant portion of the right bundle branch from the septum to the right inferior wall of the right ventricle. So to facilitate a more rapid and equal depolarization of the ventricles at the same time, it's basically a shortcut coming from the septum down through the moderator band to the other side of the ventricular wall, so that rather than having to come down through the septum, hit the bottom of the ventricle, and then come back around that lateral wall, it just bypasses it and goes across that bridge. Does that make sense? So I think that's pretty cool.
When you guys talk about as paramedics, when you say he's got a right bundle branch, is that just the problem with the electrical activity in this moderator band?
Not just in the moderator band. The right bundle branch is a pretty big structure. So you can have a right bundle branch block that's not in the moderator band, but it definitely being a part of the right bundle branch or carrying part of the right bundle branch, it can be located in the moderator band. Cool. We already talked about facilitates that equal and rapid depolarization of the myocytes within the right ventricle. Now, this is kind of interesting. It's a potentially significant source of Purkinje-mediated ventricular arrhythmias, such as PVCs, VTAC, and VFib. A lot of those can actually originate within the moderator band, which is pretty cool. The exact mechanism of the arrhythmogenesis is unclear, but overstretching, so that overfilling of the ventricle, like what we were talking about before, fibrosis comes from poor lifestyle, getting old, too many birthdays, that kind of thing, will cause buildup of fibrous tissue, and that can cause some of the arrhythmias. Ion channel alterations, those of you that are medics out there think like Brugadas, that kind of thing, ion channel alterations can cause these arrhythmias. Now, catheter-based ablation or going in and actually like surgically burning that tissue is what they use to actually treat the reoccurring arrhythmias. Next valve we're going to get into is going to be the pulmonic valve. You can see that highlighted here in that little that blue leaflet up there at the top of the right hand side of the screen. This is going to be a semi-lunar valve. The term lunar coming from the concave moon-like appearance of the cusps. It was first recorded and used the word semi-lunar in 1719. So it's been around for a while. Kind of interesting. We know it's going to be located between the right ventricle and the pulmonary artery. And it's got three cusps. It's made up of the anterior, the posterior left, and the posterior right. Am I going too fast, too slow? Am I going at a good cadence for you guys? A little too fast? Okay. Well, if you were a little bit smarter, you'd maybe keep up.
I can't, I write slow. But he'll talk fast.
Yeah. All right. It opens during ventricular systole due to the higher right ventricular pressure. So during ventricular systole, when that ventricle is contracting, it's shooting the blood out through that valve, right? So this valve doesn't have any kind of chordae tendineae or papillary muscles or anything, which we're going to continue to get into. What's stopping that blood from regurgitating back in? Any idea?
The other side inside the pulmonary.
Yeah, after it goes through, why is it not just coming back in? What's holding it together? Okay. What about the valve is holding itself closed? Why doesn't it prolapse like the tricuspid valves would? So there's a ring around the semilunar valves called an annulus. It's basically the anchoring point that holds the leaflets, and it kind of comes back down on themselves in a lip, if that makes sense, to where when the valve comes back closed, it hits an edge that won't allow it to prolapse back into the other side. Closes from the back pressure from pulmonary vascular resistance during that right ventricular diastole. So after the ventricle squeezes, it shoots out through the valve. That pressure that's residual inside the pulmonary artery is enough to push back on that valve to close it. And we already know it has no chordae tendineae or papillary muscles. Next one's going to be that mitral valve. This is going to be another one of those cuspid valves. This is known as the bicuspid. Mitral originates from the Latin word mitra, meaning mitre, or the traditional hat worn by Catholic bishops. So if you actually look at the leaflets of the valve, it looks like the funny Pope hat, and that's where it gets its name, which I think is kind of interesting. It's going to be composed of the anteromedial and the posterolateral leaflets. It's going to be located between the left atrium and left ventricle, as we know. Open during diastole, closed during systole. And it's going to prevent that regurg back into the left atrium during systole. It attaches directly to those chordae tendineae, which we're going to go over a little bit more in detail. Here we go, chordae tendineae or heartstrings. So these are going to be the fibrous bands of connective tissue that connect the leaflets of the AV valves to the papillary muscles. The main function is going to be to prevent that prolapse back into the atria during ventricular systole. And there's 3 types of chordae tendineae, and they're based on the anatomical location of the physiology. So we have the primary or marginal. Those are going to be found on the outer margins of the leaflets along the edges. They need to be a little bit more robust in order to hold those outer edges in from prolapse. The secondary or strut ones are going to be the most robust. These are the ones that are under the highest tension. They're on the surface of the anterior. And then we have the tertiary or the basal, and they originate on the ventricular wall and only attach directly to that annulus that I mentioned earlier. Then we get into the papillary muscles. These are going to be the anchors, so to speak. 3 are located in the right ventricle and 2 are in the left ventricle. We have the anterior, posterior, and septal in the right, and the anterolateral and posteromedial in the left.
So that's just one set, right? In that photo.
Yes, in this photo, only one of them is going to be highlighted so that you can just see what the idea of it is.
These are also papillary.
Yes. Actually, I don't know if I can show that on my screen or not. Do I have a mouse? Well, here in a minute, when we bring up the other part, I can go through that and show them the other ones. These are going to be contracting during the diastole to facilitate the passive filling through the AV valves. And these apply the tensile force to the leaflets of the mitral and tricuspid valves during systole to again prevent that valvular prolapse back into the atria. Next one's going to be the aortic valve. This is another semilunar. It's going to be located between the left ventricle and the aorta. I think we all probably knew that. It's composed of the 3 cusps, the left anterior, right anterior, and the posterior. It's going to be larger, thicker, and stronger than the pulmonic valve due to the higher aortic pressures. And that makes sense, right? The right side of the heart doesn't have near the pressure the left side of the heart does. So it makes sense that the aortic valve has to be much more robust than the pulmonic. Opens during ventricular systole due to the higher left ventricle pressure. And it's going to close from that back pressure due to systemic vascular resistance during diastole. Doesn't need any chordae tendineae or papillary muscles. And this is a video. Hopefully this will play for you guys. It's kind of cool. It demonstrates the heart at work. So you can see how those valves open and close in concert.
Just check it out. That's all there.
And that's showing what the electrical current is doing through the heart. Next slide. So then we're going to get into the coronary arteries. So the first thing, before we get into the arterial structure, and again, for you guys at home, I'm sorry that you guys can't see this. How does the heart get its blood? At what point during the cardiac cycle does the heart actually get perfused? Is that when the heart gets its blood to do its job? Huh? Okay. So we think of the heart as a fist, right? It sits in the center of our chest. We have 3 main coronary arteries that sit over the top of it, right? Mm-hmm. How do those arteries get its blood supply? When are they filled? Systole or diastole?
They are filled in the preload with dialysis.
It's filled in preload?
Yes. No.
No. Okay, so this is one of the reasons. So if you guys think back to like CPR class, basic BLS, what do they teach us is one of the cardinal rules of CPR, allowing full recoil of the chest, right? Why do we need to allow that full recoil of the chest?
That's when it's, the blood is starting to.
Yeah, so when we're giving a compression, I know this is kind of an offshoot here, but this is the best way to explain the point that I'm trying to make. When we're giving a compression, we're creating a positive intrathoracic pressure on the chest, right? And then when we lift up out of the chest, we're creating a negative intrathoracic pressure. In the rules of science, what is a negative pressure?
Vacuum.
It's a vacuum, right? So that upstroke on the chest is what's creating the vacuum that's sucking the blood through the coronary ostia, which is the opening in the aorta, just past the aortic valve, that sucks the blood back in through the coronary ostia, through the coronary arteries, back to where it dumps into the right atrium via the coronary sinus. So what you need to know is that the heart gets its blood and is perfused during diastole, okay? So the coronary arteries, you need to understand how they're filled, when they get their blood, that kind of thing. Cool? Any questions about that? Huh?
That's it strange. I have no idea.
All right, so then getting into the arterial structure, what these arteries are actually going to be composed of, going from innermost to outermost, we have the tunica intima, which is going to be made of the endothelium, as you can see highlighted here on the screen. And then it's going to have the subendothelial layer, as you can see highlighted on the screen now in blue. These are going to line the lumen of the artery and is in direct contact with the blood. Okay, that's going to be the tunica intima again, and it's going to be made of two layers, the endothelium and the subendothelial layer. Cool. Next one is going to be the tunica media, highlighted on the screen. This is comprised of smooth muscle and elastic fibers, and this is what contracts and relaxes in response to the physiologic catalysts of whatever we give. So if we give norepi, what is norepi? What kind of drug?
Adrenaline, drug.
Come on, my paramedic student, you should know this. What class of drug is norepi? Travis, what class of drug is it? It's vasoconstrictor, so it's an alpha agonist, right? So when we're using norepi, the part of the vasculature, the layer of the artery itself that's actually being affected is the tunica media. That's the only part of the artery that's actually smooth, comprised of smooth muscle. So that's the cool thing about the media. The next layer is going to be the adventitia. This is also known as the externa. They're pretty interchangeable. I usually heard it called the adventitia more than the externa, but if you hear externa, that's also a correct term. This is going to be mostly collagen. In the larger arteries, I think this is kind of cool. That layer is actually innervated with its own supply of nerves and vasculature called vasa vasorum. So if you ever hear that term, vasa vasorum is like a really teeny tiny micro circulation to that area. So the larger arteries have their own blood supply, which I think is kind of cool, right? There it is highlighted on the screen. Sorry, forgot to do that extra click. So getting into the specific arteries, we have the right coronary artery, or the RCA. This is going to be the one that supplies the right atrium, the right ventricle, and a portion of the ventricular septum. In about 80% of the population, the RCA is what supplies the SA and AV nodes. So how many of you guys have ever heard the term like right or circ dominant in relation to cardiology? Anybody online ever heard that term? All right, well, I can't tell if anybody's ever heard the term, but basically what that means is depending on which artery is feeding the SA and AV node is what determines whether you're right or circ dominant. In about 80% of the population, the right coronary artery is going to feed those, so they would be considered right dominant. And this is relevant for different EKG changes that you can get depending on the MI patterns that the patient has. You can tell whether somebody is right or circ dominant. This is usually the generally in most people the longest coronary artery in length. Now, looking at the right side of the screen, the picture, it's the same vantage point, I guess. We just kind of changed the angle on the RCA. We can see this little offshoot, this branch here. This is called the right marginal artery, or the RMA. This is going to be the largest branch off of the right coronary artery. This is one of the ones that we probably don't talk about as much as we should. Usually we just talk about the right, the left, and the circumflex. The right marginal is a pretty important artery too. It supplies the majority of the lateral portion of the myocardium of the right ventricle. So if we're looking for right-sided MI occlusion, typically if there is a right-sided MI occlusion, it's going to be from a thrombus in the RMA. The next one that branches off the right coronary artery is going to be the posterior descending artery, also known as the posterior interventricular artery. This supplies the posterior third of the septum, the inferior wall of the right ventricle, and a small portion of the inferior surface of the left ventricle. The next one that we're going to get into is going to be the left coronary artery. This one is a big one. It's important. If you ever heard the term left main, that's what they're referring to, is the first branch off the aorta called the left coronary artery. It ultimately supplies the entire left atrium and left ventricle. And it's only about 10 to 25 millimeters in length before it branches into that left anterior descending and the left circumflex, or that circ that I mentioned before, arteries. Now getting into left anterior descending. So when I was giving you that, what? Oh, sorry guys, not trying to go too fast. It's all that time in sales that I spent before I got into EMS. I can get going.
Let me tell you why you need a heart.
Yeah, exactly. So getting back into that fist analogy, how we have our heart in the center of our chest as a fist, we've got the three main coronary arteries. That one in the front, if you were going to set your three fingers over the top of your other fist, that's your left anterior descending, and that's what we call the widowmaker. I'm sure we've probably all heard of the widowmaker, right? Like, ooh, he was dead before you hit the floor. You had the widowmaker. Yeah. That's because this one is going to feed almost that entire surface of the anterior portion of the left ventricle. And if the whole front part of the left ventricle is impaired, how much of a total percentage of the ventricle do you think is no longer able to function? A lot. Yeah, anywhere above 40% is going to cause a severe ventricular dysfunction. So if more than 40% of the ventricle is no longer able to do its job, then you're in acute heart failure. So that's a bad day. That's why they call it the widowmaker. Supplies that entire anterior surface like we talked about, most of the septum. This is the largest artery, coronary artery in diameter. And it's also, this is kind of the crappy part about it, it's the most commonly occluded coronary artery. So not only is it the one that's going to kill you the most effectively, it's the one that you're most likely to have occluded, which kind of sucks. Then we're going to get into the circumflex artery, or the circ. This is the other branch off the left main. And the name kind of says it all, the circumflex, because it circumvents, wraps around the backside of the heart. It supplies that left atrium, part of that back of it, and the left high lateral and posterior wall of the left ventricle. So for my medics that know their 12 leads, what leads are typically going to be the ones that are going to show the ST segment elevation if you have a occlusion of your circumflex artery? Wouldn't be AVR. It's 5 and 6. So good job, buddy.
Dog.
And 1 in AVL. Yeah, 1 in AVL. Those are considered your high laterals. And if you think about it, looking at the picture of the heart, this one isn't really that great. I'll pull up another one here in a minute. It wraps around that high lateral part of that left ventricle. So that's where you're going to see it. And if you're looking at those leads, it makes sense that that's the part of the heart that you're actually capturing with the vantage point of the camera, so to speak, of the lead. This is going to be in approximately 20% of people that are going to be LCX dominant. It's going to supply the SA and the AV nodes. So why is that significant? Whether you're RCA or circ dominant, why do I care? What could I potentially see in the setting of an MI if the SA and AV nodes are occluded? Or are not occluded, if the SA and AV nodes aren't being perfused? What did you say? Junctional rhythms. What else? What? Okay, yeah, if it gets bad enough, you can see a ventricular rhythm. What about heart blocks? I know ultimately like a third degree heart block would be like a ventricular rhythm, but
John said third degree.
there you go. Perfect. Good job, John. So that's why we care. In the setting of a third degree block, why is that a bad thing? Why do we care? The heart's still beating, right?
What is the third degree block?
It's a complete disassociation. Thank you for asking the question. It's good when people ask questions. It's a complete disassociation between the atria and the ventricle. So at the AV node, think that that wire was just cut. So there's no impulses that are getting from the atria to the ventricle anymore. But because the heart is capable of automaticity, so each cell can generate and discharge its own electrical impulse, the cells down in the ventricle are going to be sitting there like, dude, what the hell? Like, feed me, where's my impulse? And then eventually it's just gonna be like, screw it, and it's gonna make its own. The problem is that the ventricular inherent rate is pretty slow. So if I have somebody that's in a third degree heart block, then odds are their ventricular rate that's actually responsible for pumping the blood out through perfusing the body is gonna be too low to meet metabolic demand. So that's bad, and you die. So that's why we care about third degree heart blocks. Next thing we're gonna get into is gonna be the conduction system. So it's kind of a nice little segue talking about heart blocks to get into this. First thing is going to be the sinoatrial node or the SA node. This is the pacemaker of the heart. Good way to think about it. It's located at the junction of the cristae terminalis in the right atrium. It's composed mostly of P cells, or pacemaker cells is the full term for it. And those are what are responsible for impulse propagation. Even though all of the cells in the heart are capable of automaticity and can generate their own impulse, pacemaker cells are more prone to do so. So they're usually the ones that end up taking on that role. This is what's going to set the intrinsic rate and cadence of myocardial contraction between that 60 to 100 beats per minute. So where we get sinus, normal sinus, sinus brady, sinus tach, it's all based on what the inherent rate of the SA node is. Anything less than 60 is going to be what? Anything more than 100 is going to be what? Very good. And it's all because of the SA node. It's going to be innervated by both the sympathetic and parasympathetic nervous systems. So this is where you're going to get the termination of both of those systems. So you're not going to be able to get any more innervation below this point, usually. Next thing we're going to get into is going to be the Bachman's bundle, or the interatrial bridge. The thing to remember about the SA node, the Bachman's bundle, also getting into what we're going to talk here in a second about the internodal pathways, is that the speed of conduction through these structures is going to be 1 meter per second. If you're taking notes, it's kind of a nerdy little fact to remember. Impress the doc and look smart, that the speed of conduction is going to be 1 meter per second through the SA node and the Bachman's bundle and the internodal pathways. This Bachman's bundle is named for Jean-Georges Bachmann in 1916. He was a French cardiologist that discovered it. Jean, whatever. Like I said, it's also known as the interatrial bundle. It's the only electrical pathway between the right and the left atrium in normal anatomy. So the reason why we have this is the same reason why we have that moderator band, is to facilitate equal and rapid depolarization of the atria in a clear, concise heartbeat. Now it is possible for us to have additional accessory pathways. What is that called? What is the accessory pathway usually called? Come on, John. Mary, what is the accessory pathway in the from the atria to the ventricles usually called? Bundle of Kent?
Yeah.
There you go.
Yeah.
Yeah. So bundle of Kent is a way that the impulse can bypass the Bachman's bundle and get from the atria to the ventricles. But in normal anatomy, where you don't have that bundle, the Bachman's bundle is the only way that you can get to both. Already talked about that. Facilitate equal depolarization. And it plays an important role in the genesis and propagation of atrial fibrillation. So similar to how the moderator band was giving us a what's the word I'm looking for? A proclivity for PVCs and things like that. The Bachman's bundle is going to do the same thing for AFib through fibrosis or calcification, that kind of thing is how you end up with AFib usually. Blocks in this bundle can produce specific diagnostic ECG changes. So do you know what you could look for on an ECG to diagnose a Bachman's bundle branch block? Any idea?
Well, I didn't cover that.
I wasn't either.
School,
Yeah, I wasn't either.
huh? No, either. It's just a French school.
No, you'll have a P wave. So
Prolonged P-wave.
good.
That's John.
There you go, John. All right.
Pull that one out of his mustache.
All right. So a prolonged P wave, that's correct. And then as far as morphology, it'll be a prolonged one. Are you thinking like a second degree type 1 heart block? The Winky Bach, longer drop? Is that what you're thinking of?
Is it by,
What?
what is that called?
So it wouldn't, it's not necessarily biphasic,
Yeah.
but you will see a notching to the P wave. So having that normal upslope rather than it being that nice mirrored on either side even P wave. At the top of the P wave, you're going to see this nick in it, like it got, like the bite taken out of the Apple logo. It looks like a notch there before it comes back down the other side. And it makes sense because the impulse is going to be traveling from right to left, right through the heart. So if we're looking at a EKG and we're looking at the P wave, we're looking at the P wave through time from right to left. So if we have that normal upslope of the P wave on the right-hand side, we get to that notch, that's where the speed of conduction has been delayed. And so the cells in the atria then have to play nudge your neighbor to get the impulse to propagate the rest of the way through the left atrium. Does that make sense? So that's why we get the notching of the P wave. So if you see notching of the P wave or an elongation of the P wave, they could have a Bachman's branch bundle block. Then we're going to get into the internodal bundles or internodal pathways. These are electrical fail-safes is kind of the way that I like to think about it. And it really kind of lends credence to the genius of the design of the heart. We have 3 separate structures. We're going to have the anterior, the posterior, and the middle. Again, just in relation to where they sit in the heart. The impulse takes approximately 50 seconds to travel from these bundles to the AV node. Again, that's at that rate of 1 meter per second. Let me go back. But the cool thing about the fact that we have 3 internodal bundles is that if one ends up being blocked, we have 2 additional fail-safes. So it's a way to make sure that we get the impulse from the SA node to the AV node in the correct amount of time, which I think is pretty interesting. Then moving on to the AV node or the atrioventricular node. This is basically just a resistor, is the way that I like to think of it. So if you guys know anything about electricity or what a resistor does, the AV node is responsible just for holding on to that impulse that we get from the SA node. It's kind of like that wait, pause, hold, now, and then it lets the impulse go. The AV node is what's responsible for that lub-dub. We're in a nice, clean, concise heartbeat of somebody that's healthy and alive. We have a contraction of the atria, our lub, and then a contraction of the ventricle, our dub. The AV node is responsible for that lub-dub. If we didn't have the AV node, the whole heart would just go boom at the same time, right? Why do we have a disconnect between the AV node, or not the AV node, between the atria and the ventricles in systole? Why do we need to have that delay? What? Yeah, for filling time, right? You guys know that the atria are almost basically worthless when it comes to the function that they serve in the heart. Atria are just responsible for that little bit of extra filling called atrial kick, which plays off of Frank Starling's law. The more blood that we can stretch into that ventricle, the more that the ventricle is going to have that contractile force when it comes back together during systole, right? So that's why we have that pause, is for that lub-dub to fill the ventricle. It's going to be made primarily of T cells. T cells stands for transitional cells. These are going to be the ones that are responsible for slowing impulse propagation. They still conduct, but they don't do so as readily as P cells do. The AV node is located at I think it's Koch or Cox triangle. I'm not exactly sure, depending on what part of the world that word came from, which is located at the septal tricuspid leaflet, the coronary sinus, and the interatrial septum membrane is where the AV node is located. It's responsible again for slowing the conduction. We've talked about that. And I think this is really cool. It's the only part of the cardiac conduction system capable of decremental conduction. Anybody heard of that or know what that is? So the AV node is really the only protecting structure from the atria to the ventricles. It's the only thing there to set the limit, so to speak, as to how many impulses can get to the ventricles. If you didn't have the AV node and you were in AFib, what is the atrial rate of contraction in AFib usually? 300, I mean, a metric ton, right?
Yeah.
So if you didn't have the AV node, how many of those impulses would be going straight down to the ventricles? 300, right? What happens if your ventricles were contracting 300 times a minute? Or it explodes, right? Like that would be bad. You wouldn't live if your ventricular rate was suddenly 300. The AV node protects it. It's a buffer system. And decremental conduction is the principle that states that basically the more often you stimulate the AV node, the more slowly it conducts the impulse it receives, which is kind of cool, right? So if I'm triggering it 60 times a minute, it's going to move X amount of speed through the AV node, still reasonably quick or whatever, let's call it. But if I get to the point where I'm triggering it 300 times a minute, the AV node itself is going to really be playing nudge your neighbor with all the cells within it to move and propagate that impulse along through rather than letting it go more readily. Does that make sense? So yeah, kind of cool. Decremental conduction. It's what saves your life. Then we get into the bundle of His. This is also part of what we would refer to as the AV junction. The AV node and the bundle of His are typically grouped together and called the AV junction. The speed of conduction through the AV node and the bundle of His is going to slow dramatically from that 1 meter per second, where we are in the SA node, the Bachmann's bundle, and the internodal pathways. It's going to slow from 1 meter a second down to 0.01 to 0.02 meters per second. So huge, drastic decrease in the speed of velocity through the bundle of His and the AV node. This is going to be named for a Swiss cardiologist named Wilhelm His Jr., who discovered it in 1893. Some useless trivia there. You can impress your cardiologist. We already talked about that. It's known as the AV junction. And this is going to be located within the superior portion of the intraventricular septum. So if you were looking at the heart from the front, from the anterior perspective, located in the top of that septum is where it's going to be. It's like right there, like kind of in front of you, facing you head on. And we'll talk about that. Continues to slow the electrical conduction, which actually, going back to the bundle of His, if I was going to have, let's say, a 3rd-degree heart block, doesn't it kind of make sense that this might be where it's located at? Yeah. What about like a 2nd-degree type 2? What do you think that is? It's going to be in the bundle of His usually as well. Cool fact, you can also tell how high or low the bundle branch block is, or not the AV block based on the width of the QRS. Anybody know that? Yeah, so you can still have a quote unquote normal QRS, it's less than 0.12 milliseconds. But if it's getting on that 0.10, 0.11, and you're showing the morphology, then you can tell that you're probably going to be higher up in the bundle than lower in the bundle. Or no, opposite. You're going to be lower in the bundle versus higher up in the bundle because it's taking longer for that impulse to propagate. Does that make sense? Useless, again, kind of piece of information. For this, then we get to the right bundle branch. I like to think of these as conduction highways. So if the bundle of His was responsible for slowing everything down, once we get to the right bundle branch, it's responsible for speeding everything back up. At the right bundle branch is where everything starts to get to that 2 meters per second in conduction velocity. So if we're at 1 meter per second, everything in the atria, the junction is going to be that 0.01 to 0.02 meters per second. And then once we get down into the right bundle branch and left bundle branch, everything below that is going to be that 2 meters per second. These are also known as the Tawara bundles, named for Sanao Tawara, who first discovered it in 1906. He was a Japanese cardiologist responsible for tons of stuff that we know about the heart. So if you're a nerd on cardiology, you've definitely heard of Tawara. Runs along the right aspect of the septum in the subendocardial layer. And the blood is usually supplied by the septal branches of the LAD. Sorry, I got click happy. So this is also the most commonly blocked fascicle of the conduction system. So if you're gonna see a block, it's probably gonna be a right bundle. No. Yeah, of course.
So when I hear a medic say, oh, there's a right bundle branch block,
Uh-huh.
I was always told that shows that they've had an MI in the past. Is that true or no?
No, not necessarily. So there's lots of different things that can cause right bundle branch, left bundle branch. MI can be like in a setting of new sudden onset bundle branch block. Then yeah, I'm going to think MI, but there are other things that can cause it. So it just kind of depends. Good question. Then we get into the left bundle. So again, it's just going to be another conduction highway. Is the way I like to think about it. Also discovered by Tawara. Runs along the left aspect of the septum. And this quickly branches into the left anterior and left posterior fascicle. So again, because the left ventricle is such a big chamber, it's a much larger surface area than the right ventricle, right? The right ventricle is much smaller. Have you guys ever done a tissue dissection and actually seen a heart, held it in your hand and looked at the difference between the LV and the RV? The RV is pathetic. I mean, it doesn't even hold a candle to the size, the mass, or the sheer volume of the left ventricle. So in order to, again, facilitate that equal and rapid depolarization of the ventricles together, because we want to have the right and the left working in concert, right? The left bundle quickly branches into that left anterior and left posterior fascicle. So that's to, again, facilitate that rapid depolarization. It's going to go down the front side and the back side of the heart to get the entire LV to contract at the same time, rather than having it to play that nudge your neighbor to, and ultimately be slower than what the right bundle would have done for the right ventricle. Does that make sense? Mm-hmm. So that's why we have it split.
Will you explain how the conduction system in a bundle branch block will move through the entire?
Yes. So you want to go through like how it depolarizes from outside to inside and all that. Okay. So I don't have anything to really show anybody online, but basically the best way to think about it is that the impulse travels from the atria down through into the ventricle. It goes down through the septum, branches out through the bundle branch blocks, or not bundle branch blocks, through the bundle branches. And then it ultimately interfaces with these things called Purkinje fibers. We're going to get to them here in a second. Actually, we can go ahead and just skip to that. And I can explain this and it might make all of it make a little bit more sense. So if the bundles are the conduction highways, then the Purkinje fibers are like the side streets that get all the electrical impulses to all the little nooks and crannies of the heart. Does that make sense? The Purkinje fibers are what actually interface with the cardiac myocytes to trigger or turn on that cell. The impulse comes down through ultimately to the Purkinje fiber. The Purkinje fiber knocks on that cell and goes, hey, special delivery. And the cell goes, oh, cool. And it contracts and it moves on to the next one. So that's what the Purkinje fibers are for. Named for a Czech cardiologist, Jan Evangelista Purkinje, who discovered him in 1839, which is kind of crazy to think about. Purkinje fibers, and as with pretty much all the electrical system, it's not like a nerve where you can just dissect the whole electrical system out of the heart. Like if I cut open the heart, I can't be like, oh, there's the SA node, there's the AV node, or, here's this little string that I'm holding in my hand that's a right bundle or a Purkinje fiber. They're indistinguishable from the rest of the cells around them. They just have specific properties that allow them to propagate the impulse a little bit more efficiently. So to think about that, this guy discovered these in 1839 when it's not even an actual structure that you can hold in your hand. That's pretty cool, right? Or maybe that's just me. Maybe I'm just a nerd.
You're
Yeah. These are also going to be known as subendocardial branches. And they are the ones, like I said, directly interface with the myocytes to initiate phase 0 of the cardiac action potential. Do we know all the different phases of the cardiac action potential?
The phases, no, I would.
No? Mary? What are the phases of the cardiac action potential? Yeah.
1 through 4.
1 through 4. All right, well, we have
0.
0. Yeah, there we go. 0 through 4. So, hey, John, you want to take a stab?
Sorry, no.
Okay, so we have phase 0. Phase 0 is going to be depolarization. That's where the initial influx of sodium and efflux of potassium is going to take place. That's what causes the electrical gradient to shift, which gives us the cardiac contraction. Travis is doing things.
I'm following what you're saying.
Oh, okay. So that's going to be phase 0. That is called depolarization. Phase 1 is going to be the rapid repolarization. And that's going to be basically where the potassium and the sodium are starting to shift and go back the way that they came. Phase 2 is what we call the cardiac plateau. This is what gives the action potential of cardiac cells the unique inherent difference from the action potential of, let's say, nerve cells or any other action potentials in the body. This comes from slow calcium channels that are being opened. That calcium is basically the nerd that follows sodium around and holds the door open for sodium and allows more sodium into the cell when calcium opens, which then propagates the electrical potential for longer. So we have a what's the word I'm looking for? A continuation of the polarity at that level. If that whole waveform is the amount of electricity that's moving, that's why we get the plateau, because we're moving more sodium into the cell with phase 2. Then we have phase 3, which is the rest of the repolarization. This is going to be the sodium and potassium. They have fully are beginning to fully finish switching back to their original roles. So we've got sodium moving out of the cell, potassium moving into the cell. Then we have phase 4, which is resting, where we have now reached homeostasis again before we depolarize in the first place. All the sodium is going to be extracellular, all the potassium is going to be intracellular. And then we get another propagation. Cool.
This lines up with like,
The QRS.
yeah.
Yep.
Okay.
Yeah, so if you draw a QRS right over that, that's exactly what's happening.
Okay.
Yeah. Yeah, perfect. You're like my Vanna White. I love it. All right. So for those of you online, you missed kind of a pretty cool little drawing that Travis did, but we were just going through the action potential. And the action potential, there's a lot more to it than what I can explain quickly in 30 seconds, but it's the basis of everything. Your whole body is basically one giant battery.
John says he remembers now.
There you go. That a boy, John.
It takes a minute for like, and I'm sure,
Yeah.
you know, like you're like, oh yeah, I remember that.
Yeah. Well, he was there when it was discovered, so it's. Sorry, John. I'm just messing around, buddy. So yeah, the Purkinje fibers are what are going to interface with the myocytes to get them to start phase 0. This is kind of cool too, is that the Purkinje fibers are insulated from each other by what's called the cardiac skeleton. So there are actually a whole like complex interconnected skeleton basically of connective tissue that isolates different parts of the heart from different parts of the heart. So that's why, like, if I start in action potential up in the left atrium, it's not going to be able to get to the left ventricle without going, or not left, right atrium to the right ventricle without going through the SA node, the internodal pathways, and the AV junction. It can't get there. So the Purkinje fibers, they're insulated to where this fiber, when it interfaces with this myocyte right here, this electrical impulse can't trigger a cell over here because they're insulated from each other by these collagen fibers called the cardiac skeleton, which I think is, again, kind of interesting.
It can't skip over cells.
Yeah, it can't skip over cells. It can't leapfrog. It has to be triggered by the specific Purkinje fiber that interfaces with it. Does that make sense? Then we get into the fun stuff, pathology of an MI. So I know that this was originally billed as a cardiovascular lecture. The thing is, though, is that there's so many different things and nuances to the cardiovascular system, all the different pathologies, the etiologies of what can go wrong with our patients, and then getting into the treatments of each one of these individual things. We'd be here all night, especially because I like the sound of my own voice and I'm a nerd. So we're probably just going to cover MIs tonight, and then in a subsequent lecture, we'll get into more of the cardiac type stuff that we want to know, okay? So here's a cool little video of the pathology of an MI. Just puts a little bit of a visual to what's going on in the heart. See that coagulation of the blood from the stasis? And then we can see that lesion becoming necrotic and the heart no longer being able to pump the way that it should. So, let me minimize this. Okay. A myocardial infarction or heart attack is what happens from the lack of blood flow through the coronary arteries. We all know that, right? Lack of anastomosis. I don't know if I'm pronouncing that correctly or not, but basically what those are is the collateral circulation from one part of the heart to the next. Different parts of the heart are fed by specific arteries, and there's not really any bypass tracks within the heart. That's why the heart is susceptible to heart attacks and myocardial infarction. Same thing with the brain. The brain doesn't have very many of them either. Whereas if I have a little bit of an occlusion in an artery in my arm, there's whole bunches of different side streets and multiple sets of vasculature that can get the blood to where it needs to go around that thrombus. Does that make sense? So the lack of those between the coronary arteries is what ends up leaving the heart at risk of ischemia and ultimately infarction when the flow through the vessel is compromised due to either atherosclerotic rupture or acute spasm. Those are the two main causes of MI. The most common is going to be that atherosclerotic rupture, but it is possible to have acute spasm. What is the one most famous drug that is infamous for causing acute coronary artery spasm? Killed Chris Farley. Cocaine. Cocaine is really, really good at causing coronary artery spasm. So if people that take too much blow have a heart attack, that's how they have the heart attack. Is the coronary artery has spasmed and closed off, similar to what we think of as like what causes bronchial spasm and how people can't breathe with asthma or COPD. It's the same thing, but happening in your coronary artery. And if it clamps down, you can't get any blood past it. That's bad, and you die.
T's and P's just
His weight probably had a lot of cholesterol.
Probably.
and cocaine.
And cocaine. Cocaine. Okay, so coronary artery thrombosis, which is the process that ends up causing acute MI, is when the fibrous cap of the atherosclerotic plaque ruptures within the coronary artery, and it exposes this thing called the internal necrotic core. And again, there's pictures. I'll show you exactly what this is. Once exposed, the thrombogenic contents of the necrotic core interact with the platelets within the blood. It triggers the extrinsic coagulation pathway, And that ultimately catalyzes the platelet aggregation and thrombus formation that causes the heart attack and how we die. Does that make sense? That's what I'm talking about here.
Yeah, but I don't understand, like, how does it help you as a paramedic to recognize where the thrombosis is in the heart? Is there any different procedures you can do if you recognize it's in the left port area or the right?
Yeah, absolutely.
Okay.
So that's a great question. Nitro. So we all know nitroglycerin, right? We'll cover it here in a little bit more detail later on. But real quick, what is the one setting of MI that I don't want to give nitro? John?
Their blood pressure.
Posterior.
Well, you're right about blood pressure.
Yeah, you want.
That's a contraindication, but there's one type of MI that I don't want to give nitro.
Inferior.
Inferior. Why inferior?
Because it lowers your blood pressure will be lower than lower blood pressure.
No. So when we're referring to this is, I think, a common misconception. When I refer to somebody's having an inferior MI, what part of the heart is not working? Well, thank you. But
Inferior.
yeah, okay. Maybe let me rephrase the question. Is it the left ventricle? Is it the right ventricle? Is it the what is it? Left ventricle. Because what does a 12 lead look at? Does it look at the whole heart? No. The 12 lead is designed to look at the left ventricle. Now we can capture little pieces and snippets of other parts of the heart with a normal standard 12 lead, but if I refer to a normal inferior infarct, I'm talking about the inferior portion of the left ventricle being impacted. That's not a big deal for nitro, but what typically goes along with an inferior infarct? What other parts of the heart can usually be affected? The right ventricle, right? Because the inferior portion of the left ventricle is fed by the same supply that feeds the right ventricle, right? Through that posterior descending and the right marginal, yeah? So depending on where that clot is, I could have right ventricular involvement. If the right ventricle isn't able to do its job the way that it normally should, then what does that end up doing to preload and the contraction, forced contraction of the right ventricle?
Weakens it.
It decreases it, right? So right ventricular MIs are preload dependent, meaning I don't want to drop their blood pressure, right? So if I see on a 12 lead that they're having an inferior, posterior right-sided involvement type of an MI, and I give them nitro, I'm going to tank their blood pressure. And remember, the left heart can't pump out what the right heart doesn't receive. So that's why this stuff matters, is because you can tell where things are. You can actually, on a 12 lead, tell where the rupture was, if they're right or circ dominant, whether they've had an old MI in the past. You can tell whether the right side of the heart is just pissed off. I mean, it's literally the language of the heart. So that's why 12 leads are cool.
See a decrease in blood pressure with the inferior
With what?
or with the inferior?
A decrease in blood pressure?
Yeah, we see that at all. Like, will it be lower than what you expect?
That depends on how far along the process is for that patient. So if they've progressed from acute MI into like acute heart failure, then yeah, it's potential that that's eventually going to progress to a cardiogenic shock, which is going to lead to a low blood pressure, right? But it just depends on where we are in the process. So yes and no.
But basically, you'll slow the volume of the blood needed to. By doing that, would you trigger an SVT or anything like that? Because the heart doesn't have that blood, so is it going to start freaking out on you, or?
No. I mean, anything's technically possible. This is the thing, is that I'm sure somewhere there's a case study where somebody had SVT triggered from nitro that was given in a inferior, like it probably exists. But in general, that wouldn't be the pathology that would result. It would just be the preload tanks with preload tanks and the afterload tanks, BP drops, they end up getting loopy, passing out, dying, that kind of thing. Okay. All right, so as far as the thrombogenic process, that extrinsic coagulation pathway, remember we have an intrinsic and extrinsic pathway for coagulation. This process triggers the extrinsic, which would be the same as if that you had gotten cut, or like any kind of trauma triggers an extrinsic pathway. And then platelet aggregation, that term you've probably heard before if you remember what aspirin does, aspirin being an antiplatelet aggregate, right? So it's going to stop those platelets from getting sticky and clumping together. This process here, though, is what's actually making them want to stick together in the first place. So looking at this picture, I don't have a mouse that I can show you guys here on the screen. Do you see the very outermost layer on the right side? that's going to be our tunica adventitia, right? And then when we move into that little slightly more inward, kind of bubbly, looks like little wads of bubble gum layer, that's going to be that tunica media. That's that smooth muscle layer that's responsible for contraction. And then you can see right past that elastic membrane of the tunica media, how we start to build this fatty plaque atherosclerosis. This is basically caused from deposits of fat tissue, excess of calcium. So they actually, that's why it gets hard and kind of like almost chalky. If you've ever seen one in a tissue lab dissection. And then that innermost layer that is of the artery, we see that tunica intima, which is comprised of that endothelial and subendothelial layer. That layer is usually only about 1 cell thick, and it plays for a little bit further into the process as to how this causes an MI. As the plaque worsens and gets bigger, you see how the lumen of the artery that's left for the blood flow to move past the plaque is getting to be narrower and narrower. This is what you think of typically as like an angina. So somebody that goes out and mows their lawn, gives them chest pain, they take a nitro, they sit back and relax for a little while. As oxygen demand decreases in the heart, their pain goes away. It's usually from stuff like this, where you've just had a narrowing of the coronary artery. You follow me? Cool. What causes rupture can be tons of different things. It can be just over time, what ends up happening as that plaque starts to build up, that subendothelial layer is again only about a cell thick. It can cause permeability between those cells to where you end up with this leaking basically of the contents out through those cells. As those cells begin to leak those contents into the blood supply, that's what triggers the want to clot for the blood, basically. So as you see it ruptures through here, the whole body treats it like an injury, and it starts to send everything to it to plug it up. The unfortunate thing is that that plug is what's also continuing to narrow the lumen of that artery, sometimes to the point where it's fully occluded and no blood can get past it at all. Make sense?
So the aspirin that we give is better to make it platelets slick and let this happen. than
Exactly.
try to block it.
Yeah, so a lot of people say like aspirin is a blood thinner, it thins your blood. No, it doesn't thin your blood. It makes your blood slippery. That's all it does, is I'm trying to stop this clot from getting any bigger. Does that make sense?
Yes, sir.
It's already going to start to build on its own, but if I can stop it from getting any bigger between now and when I get to the hospital, then maybe we can keep this cardiac tissue alive long enough for PCI or going to the cath lab to actually do them some good. Cool.
How long does it take to, once you ingest it, to get into your bloodstream and get up to your heart?
So this is why we chew it up. If I give you aspirin 325 PO and you swallow it, you're looking at upwards of an hour before it starts to have the antithrombolytic effects that we want in this situation. We chew it and swallow it because when it hits the stomach, it's going to go and spread out and have much more rapid absorption. So it's going to be within like the 10 to 15 minute range, it starts to take effect. So this is getting into the zones of ischemia and what's actually happening in the tissue when the tissue starts to die. The whole going, gone, that's totally true. Time is tissue when it comes to MIs. What we can see here, I wish that I could actually see it, but this is blocking my screen. Oh, there we go. Cool. Is the area, sorry, this is being done.
See the top left symbol,
Yeah.
that straight line.
I don't have a mouse.
Oh, that's good.
Yeah, there's no mouse here
Oh, you need-
because I'm guessing. I don't know. Okay, sorry guys. I just need to be able to read both sides of this. So the different zones of ischemia, we're going to have first the zone of necrosis. That's going to be that area on the very inside portion of the lesion. That's going to be made up of dead tissue. That's all gone. There's no saving it. Doesn't matter when you get them to the cath lab, that stuff's going to be done. It's going to end up turning into scar tissue. And that is no longer going to be able to effectively contract. And when it's not able to effectively contract, then that's how we're going to end up with what's going to lead to eventual heart failure. The next is going to be the zone of injury. This is where some tissue is still salvageable. So even though in general, the heart doesn't have a whole lot of that collateral circulation, those anastomies or however you pronounce it, some of the immediately surrounding tissue is still salvageable with reperfusion. So it's definitely dying. It's not getting the oxygen that it needs in order to be in aerobic metabolism. It's building up a lot of acidosis. Definitely not good for the tissue, but it's not all hope is lost. Then we get into the next zone. Where do we go? This is going to be the zone of ischemia. This is where full recovery is possible with rapid reperfusion. So getting into that whole timeless tissue thing, it can be a pretty large area of the myocardium that can be brought back if we rapidly reperfuse that area. Well, thanks, dude. That would be Travis. We can thank him for that. Anybody have any questions, by the way, on anything? Okay. One more. Is there a click? There we go. Yeah, that zone of ischemia is going to be made up of ischemic tissues due to that collateral circulation. So what is the difference between, dead, dying, ischemic? What do those words mean to you? Is ischemic dead?
No.
So what is this? So is it a lack of oxygen or is it a lack of blood flow? What does the word ischemic mean? Lack of blood flow, right? So that tissue is ischemic because of a lack of blood. Thank you. That's what I was trying to do that whole time, is minimize it.
There's no yeah.
You're a genius.
No.
Okay. So yeah, that ischemic tissue just isn't getting the blood flow that it needs because of that. It's getting to be hypoxic. Okay. Fun fact, and I think this is really cool. There's a thin layer of the myocardium beneath the endocardium of the left ventricle that can actually be perfused by direct diffusion from the oxygenated blood in the ventricle. So you guys know the layers of the heart? What are they? So what are the layers? Somebody's got to know them. John? Travis? Huh? Epicardium is the what? Outermost layer. Okay. And we have technically two different layers of the epicardium. We have the visceral, which is what? What's a cardiac tamponade? Where's that at?
It's on the outside of the heart, like in the bag outside the heart.
Okay, so that's the pericardium. The pericardium is a part of the same layer as the epicardium. They're actually the same tissue that just ends up folding over on itself. So from the outside, we have the epicardium. Then we have the myocardium. So what does myo mean?
Muscle.
Muscle. So this is the part of the heart that actually does the contracting, right? Kind of like the tunica media in the artery is the myocardium. And then we have the endocardium. And the endocardium is going to be comprised of that endothelial and subendothelial layer in the endocardium. So part of the innermost layer of the heart, as it fills with blood, is actually receiving a little bit of oxygen just from the blood being in the ventricle. It doesn't matter that it's not receiving the blood through the coronary artery, which I think is pretty cool. Huh? Oh. So then we're going to get into treatments, and then the PowerPoint is almost done.
Wait, were you going into the visceral and all the other? in between?
Oh, that's just part of the pericardium. Yeah, so no, it's just multiple layers within the pericardium. And I'll be honest with you, I don't remember each and every single one of those right off the top of my head. So when it comes to treatment of MIs, this is the part of the class that I wanted to open it up to a little bit more discussion. I wish I had more of you guys online actually in the classroom here, or if we could figure out a way to unmute you to where we could hear you.
Yeah,
But we all have different levels of experience. We've all seen and interacted with different types of patients or cardiac patients over the course of our careers. When it comes to treatments, The textbook is going to give us that acronym. What is that acronym called? MONA, right? MONA is the old school one where, what does that stand for?
Morphine, oxygen.
Morphine, oxygen, nitro, aspirin, right? Now, is it still MONA or did we change it? It's still considered the MONA. It's FONA, right? FONA, F for fentanyl, right? The reason,
Oh, you're going into that. I said why?
the reason for that is morphine has actually been associated with a higher rate of morbidity and mortality in acute MI patients than fentanyl has.
Why?
Basically, it comes down to oxygen requirement, oxygen demand of the heart. Again, not a whole process that I know just off the top of my head, but it ultimately boils down to oxygen demand of the heart. So it switched to FONA, fentanyl being the F for that. Why would we want to give fentanyl in an MI?
Blood pressure, which,
No.
no,
Because it hurts.
In certain types, maybe in certain situations in cardiovascular patients in general, lower blood pressure could be advantageous.
John says reduces preload. But reduces preload in us.
Okay, so it can reduce preload depending on the etiology of the MI. It could potentially be a benefit, but that's not why we give it. We give fentanyl, what?
Sure.
Yeah.
Time.
No, we give it for pain. That's the sole reason why we give,
Everyone's looking into it super deep.
Because it hurts.
Yeah.
That's what they gave.
but it's a benefit to the patient other than it hurts. No, I'm not saying like we need to be bleeding hearts and relieve their pain. No, nobody's ever died of pain in the history of the world. They'll be fine. The reason, oh, go ahead.
can I like share my thought
No.
process?
Yes, of course.
Okay, so you're giving it for pain initially,
Mhm.
which is why it's the F and the acronym. But then if the nitro's not working, you can use it secondary to help with preload, right?
The fentanyl is not given to do anything to blood pressure. The point of giving fentanyl is not to affect blood pressure. Does it have effects? Can it have effects on blood pressure? Absolutely. But I'm never giving fentanyl in the setting of an MI to affect the blood pressure. That's not my goal.
Okay,
So fentanyl, the reason why I give it is to reduce pain. If I'm reducing pain, what does that do for the patient in the setting of heart attack?
Making them more relaxed.
I'm making them more relaxed. If I'm relaxing them, what's happening to the heart? It's relaxing. It's myocardial oxygen demand is decreasing, right? So I already have this coronary artery that's blocked off. There's not enough blood and thus oxygen getting past it to the tissue. But that tissue, if they're all ramped up downstream, needs more oxygen. If I can calm everything down, then that tissue is starting to scream less for oxygen. So it lessens the symptoms. They're going to feel less pain. And it's also going to cause or buy them more time to where I can get them to the cath lab and reperfuse that tissue before it dies. Make sense? So that's why we give fentanyl. Now, getting into fentanyl, it's about 50 to 100 times more potent than morphine. So morphine being a hell of a drug, fentanyl being 50 to 100 times more potent. It doesn't take a whole lot. That's why we dose fentanyl in micrograms. It agonizes mu opioid nociceptors associated with C fibers. So basically what this means is that you have opioid receptors all through your body, all over the place. And they're associated with these types of fibers called the nociceptors that there's different types depending on whether it's a kappa receptor or a mu receptor that are associated with a specific type of nerve fiber. So these ones are associated with C delta or C fibers, which are unmyelinated. So myelin, we know what myelin is. It's the sheath of nerve tissue, right? What is that sheath responsible for? Why do we have the sheath on most nerves?
Insulation.
Insulation, which does what to the impulse?
Makes it go faster.
Makes it go faster, right? So if you have a myelinated nerve tract, then it's going to propagate that impulse much faster. It's going to insulate it from that surrounding nerve tissue. And so that's how you're typically going to get that somatic pain where patients can point to it and say, hey, my chest hurts right here, is because it's myelinated, right? It's very fast. It's easy to localize. These mu receptors are associated with the C fibers, which are unmyelinated. Those are responsible for that dull, diffuse pain. This is why in an acute setting of an MI, we see that Levine sign where patients just clutch their chest like this. And they're like, I don't know, my chest feels messed up here. And they draw a big circle on the chest. It's because they can't pinpoint exactly where it is, right? Fentanyl is God's gift to this. It is designed specifically for the mu opioid receptors. So it shuts down that nerve tract. Fun fact, there are actually kappa receptor opioids that will do a heck of a lot of a better job for like sharp pain. So like, believe it or not, fentanyl for a broken leg is not the end all be all. There are better drugs out there for that kind of thing. But anyways, I digress. What it basically does is it causes a decrease in cyclic AMP, or CAMP for short. CAMP is a cyclic adenosine monophosphate. The best way that you can think of what CAMP is it's basically the light switch for ATP to do its job in the cell. We all know what ATP is, adenosine triphosphate. That's the currency that our body spends to do whatever the cell's job is. CAMP is a light switch to allow that currency to be spent. So if it decreases the conductance of CAMP and it decreases the conductance of calcium, those are both responsible for neuromuscular propagation of the impulse. So if the nerve isn't able to propagate the impulse, then it's not able to get it to the brain's not able to perceive it. You don't end up feeling the pain. The other way how it does it is it causes an increase in potassium conductance. So it plays with the action potentials basically of the nerve cells. And that's how we get the blockage and pain. For adults, our dose is going to be 1 to 2 micrograms per kilogram, IV-IN-IM. Now for our protocols here at MCAS, what it says specifically for adults is 25 to 100 micrograms. In general, if you read any textbook anywhere, it's going to be 1 to 2 micrograms per kg. Okay. Then we get into oxygen. This was my favorite slide to create because it's kind of funny. But what else? What do I say about oxygen? We all know what oxygen is. We all know what it does, but I had to fill up the page. So oxygen is comprised of 2 oxygen atoms to make up a single oxygen molecule. Kind of cool. It's colorless, odorless, and tasteless, as we all know. And it's required for life. Duh. It allows the cells to complete the Krebs cycle and keep the cell in aerobic metabolism rather than anaerobic metabolism. Why do we care about aerobic versus anaerobic and how this sets into or plays into the setting of MI?
Because if you go anaerobic, you're going to have some problems with acidosis, which is going to throw off the metabolism of the potassiums and other elements that you use to charge your heart and make it work.
Totally.
Right.
Yeah. So when I'm not only that, but also energy production. If I go through the entire Krebs cycle, the electron transport chain, the whole process of using oxygen and glucose to form energy, how much ATP do I produce? 38. I produce 38 ATP. If I am in anaerobic metabolism, how many ATP can I produce? Yeah, 2. Not even close to efficient, right? And you're building up all that acid, which causes all kinds of problems because acid, as we produce more acid, our cell membranes break down. We leach out potassium. Potassium is really good at causing what? If you have too much of it? Arrhythmias. Yeah, so that's why we care about that. Oxygen, you need it. Target saturations during MI should be between 94 and 99%. It used to be back in the day that you just flooded everybody, blast them with, non-rebreather cannula, bag them on top of it, just give them all of the oxygen. We know now that that's not necessarily a good thing, right? We don't want to put oxidative stress on our patients. So try to target that 94 to 99. Stay away from the 100% saturation because SpO2s, can they measure 110%? No. Can they measure 150%? No. So if it says 100, we don't know whether they're actually at 100 on the NASDAQ or if they're at 150. So that's why we want to titrate it to between that 94 and 99. Savvy? Treat your patient, not the monitor. Huge thing. So SpO2 in general is one of those devices that EMS and medicine as a whole has developed into using as a crutch. Don't rely on your SpO2. SpO2s can be notoriously faulty, right? How many things can throw off an SpO2? Give me an example. Huh? Nail polish. What else?
Cold hands.
Cold hands. What else? CO. Yeah, because it'll say 100, right? And yet they're not actually getting any tissue or any oxygen to the tissue. What else? Bumps on the road. Light. Ambient light. If it's too bright in the patient compartment or outside or wherever you're using it, yeah, it can throw it off. And with what you said about cold hands, what can cause cold hands?
Your heart stopping?
Yeah. So that's
Hypothermia, right?
Basically, yeah.
And pathologies, etiologies of shock. So if you have a patient that is in shock, their odds are their SpO2 is going to be garbage or not work. Circulation, yeah, perfusion, right? So if you're in a state of poor perfusion, how well is that nail bed going to be perfusing and able to actually relay the pulsatile flow to it to give you the reading? Exactly, yeah. So treat your patient, not the monitor. Then we get into nitroglycerin. It's the active ingredient in trinitrotoluene. You know what that is?
Yeah.
It's TNT, dynamite.
Oh,
Yeah, this is the same kind of nitroglycerin that's unstable and highly explosive. That's what our patients put in their bodies. Yeah. Trinitrotoluene. Yeah, that's where we TNT, trinitrotoluene, TNT. Yeah. So strap in for this one. This is how basically nitro works. Nitro is converted to nitric oxide. I'm sure you've probably heard of nitric oxide at some point, especially if you have like a history of going to the gym, bodybuild, and using pre-workouts, that kind of thing. Pre-workouts are usually packed with nitric oxide boosters. That's what gives you that tingling feeling if you were taking a good pre-workout. It's from an increase in nitric oxide. That then activates the enzyme guanylate cyclase. The activation of that enzyme is what ends up creating a process that eventually leads to the dephosphorylation of the myosin light chain of smooth muscles. So that's basically a really fancy way of saying that it makes the muscle little microfibers that cause contraction in the vasculature not able to hold on to themselves. So it causes it to relax and vasodilate. Make sense? So it's an inhibition of an active process that causes the passive process of dilation. Cool. Am I just like melting face? She's falling asleep over here. Are you guys still with me? Okay. And that ultimately is what causes the relaxation in the veins, the arteries, and the cardiac tissue. That's why we give it. We give it also for the abasion of pain. Nitro has never been given, and there's not any studies to support that we give nitro to cause vasodilation to increase the flow around a thrombus. That's not what we give it. It's again for abasion of pain. Our dose for nitro is going to be 0.4 milligrams sublingual in the setting of MI or potential MI chest pain.
Like 1 or 2 mics per kg.
1 to 2 mics per kg. Our protocols here, which I operate with our protocols, is 25 to 100 micrograms. Then we get into aspirin. So we've just been going through that FONA acronym. Aspirin. What is the actual name for aspirin? The drug name? Nope, that would be Tylenol.
Oh,
It's an NSAID.
It is an NSAID. Good job. Air 5. P student, come in clutch. What is aspirin? What's the actual drug name?
John says acid.
Acetyl salicylic acid, ASA. If you've ever seen it like in your charting or whatever, it's labeled ASA.
That's just the easy way to find it. I don't like typing that.
Acetyl salicylic acid. So it's a salicate is the type of like molecule or whatever it is. Fun fact, if you're allergic to oil of wintergreen, which is also a salicate, you can't give your patient aspirin. If somebody's allergic to oil of wintergreen, they're probably allergic to aspirin.
They didn't go over that in the MT school.
Fun little fact.
Don't look at me.
Um,
Supposed to go to.
I'm sorry, say one more time. If they're allergic to what?
oil of wintergreen.
Oil of wintergreen.
Yeah, it's like a natural herbal type thing. People use it for different types of stuff. But if you're allergic to that, being a salicate, you're probably allergic to aspirin.
Won't they just know and just tell you they're allergic to aspirin?
No,
Hopefully.
and it's also a setting of what does that do to you? That's important. If somebody's having 10 out of 10 crushing chest pain and they tell you that they have an aspirin allergy, what's a follow-up question that I'm going to ask right away? What does it do? Because if it just makes your tongue a little itchy, I don't care. Take it. You're gonna take that aspirin. Because do I want your tongue to be a little itchy and have you live, or have you die because I didn't give you the aspirin? Yeah, exactly. If they're like, oh, my throat closes and I stop breathing, oh well, then maybe we won't give you the
They were
aspirin.
gonna get it at the anyway.
Yeah, yeah, that's a good thing to give in the setting of MI is a whole bunch of epi.
Let's do opposite of. what
Yeah,
we're
let's
actually
just
trying
kill
to
our
accomplish.
patients. Yeah.
We're just gonna speed this. up.
Angels of death.
Yes, that's
Just,
right.
just show up with a pillow rather than a jump bag. So yeah, aspirin is the coolest part of this whole acronym. It's an NSAID, which is more directly classified as a non-selective cyclooxygenase inhibitor. Basically, what that goes along with is the production of prostaglandins. Prostaglandins are what's responsible for inflammation, or part of the inflammation process in the body. It also takes pain impulses that would normally be at like a 1 or a 2 in the body and amplifies them up to a 6, 7, or an 8. So if I can inhibit prostaglandin, then it'll not only inhibit the pain response, but it also inhibits the platelet aggregation through inhibition of thromboxane A2 and prostacyclin. Those are the two things that end up triggering platelets to want to stick together. And aspirin directly says, no, you're not allowed to do that. And it inhibits those two things. Aspirin is the only medication proven to reduce morbidity and mortality in acute MI. Out of every drug we've ever given for any kind of setting of chest pain and heart attack, aspirin is the only one definitively proven to up your chances of survival. So if you have your choice of giving them one thing, always go for the aspirin, right?
And you said that the aspirin mechanism that makes it slippery as far as.
Yeah, it's an
So
antiplatelet.
I have a question.
No, yes.
Yes, I do. And so I started taking aspirin at a certain age, just one a day.
Prophylactically.
And now there's a study that says there's no study that actually supports that that's going to help.
Yeah,
Have you heard anything about that?
I've heard about that. It's kind of like a newer kind of emerging study. I don't know exactly why. I think it has something probably, if I had to take a guess, at the low dose, being that there's a therapeutic range of when drugs become most effective, like the ED50, and you'll learn all about this at some point. If you like, I don't know, go to paramedic school. And sorry.
That probably was.
My bad. Basically, your therapeutic dose range for the drug and how long it's in the system overall before it gets metabolized has an impact on what it's going to do to platelet aggregation. So in the setting of acute MI, I'm giving you 325, you're chewing it up, you're swallowing it now, bang, it's becoming effective in your system. And I only need it to take effect for so long to save your life now versus one little 81 milligram tablet on a prophylactic once a day basis probably is just like a drop in the bucket that evaporates before the bucket fills up. Does that make sense?
Yeah.
Cool. Dose is gonna be 325 PO. Cool. So that's everything for the slideshow. What I had left for the rest of the class, I just want to share. Yeah, sure. Talk about what have you guys seen in the setting of chest pain from your patients? Talk about how an MI presents and what we'll see from our patient. That's just as important as talking about the nerdy pathophysiology of everything. How do chest pain patients typically present?
They will say crushing pain.
Crushing pain. What other
An
types of
elephant
words?
sitting on the
Elephant
chest.
sitting on their chest. What else?
Radiates to either radiates from the right side to the center.
Usually radiates to the left side, right? Is the textbook. Now, keep in mind, our patients' bodies don't read our textbooks. It can definitely radiate down the right arm or up on the right side of the face and the jaw. Textbook is going to say it's going to go down that left arm or up into the left side of the jaw and the face.
I was gonna say jaw pain.
Jaw pain. Who is that?
John Zink.
Zinc.
Oh, what's up? Yep, jaw pain. That's what else?
Abdominal pain in women?
Abdominal pain. Yeah, that's a good one.
Back pain in women as well.
You both, yeah. Amazing woman. Okay. Really, in general, you can end up with malaise, right? Diaphoresis, that's a big one. Now, when we think diaphoresis, are we thinking like, oh, it's a little warm out. I gotta tap.
They're on the 12 joints.
Yeah, it's like wring out a shirt wet, right? These are the kinds of patients that if they're having a real true acute coronary, crisis, you walk into the room and from across the room, you're like, oh, you're about to die, right? What?
They'll say fatigue as well.
Fatigue? Yeah, malaise, fatigue. Yeah, same thing. What else?
Is that your dog?
Shortness of breath.
Shortness of breath. That's a big one. Along with abdominal pain, maybe like nausea. Not just the pain, also nausea.
With that, they can't
We-
walk.
Yeah.
We had one that was swearing they had torn his shoulder working out.
He had torn his shoulder working out.
That was what his mind was telling him when he was having a full heart attack.
Okay, yeah, absolutely. So I didn't run this. There's a couple other things that you can add into this. Women, we know, present different than men for the most part, right? They typically are more the silent MI, if you ever heard that term, is typically women more so than men. So a lot of times in women, you'll get more of the psychological symptoms. Nausea is a huge thing. If you ever have a woman with any kind of chest discomfort and associated nausea or abdominal pain, assume it's an MI until proven otherwise. But it's also things like that feeling of impending doom, right? The just really anxious, on edge, uneasy, not able to settle. My dad, for those of you that don't know, he's a paramedic as well. He's been a medic for like 30 years. And he told me about a call that he ran one time, which I thought was pretty interesting. He showed up to this lady who was just not feeling right. She called. It was like a nondescript kind of a dispatch note on why they were getting toned out. Get there, and the lady's just like, I can't settle. I can't, get comfortable, whatever. And she's like obsessively cleaning the house when my dad shows up with his partner. Just neurotic, scrubbing the stove with a Brillo pad. Gets her on the 12 lead, and she is having a massive MI. No other associated signs and symptoms at all. All she was really on edge and felt like she had to clean. So yeah, any kind of those mental type symptoms, those can typically plague women more so than men. Anything else? Numbness. Yeah. What could be numb? Where could you feel some numbness?
Then it also the left side.
Yeah, typically. Yeah, running down the left side. Anything else? And coming from your guys' experience, you guys have all been in the field for a long time. What else have you seen?
And then it's freaking altitude sickness.
Altitude sickness? Okay.
I have a
Turns out to be
question
little bit.
as to what, since COVID, what you guys have been seeing in the field. What we've seen is a lot of young people with chest pain. I mean, they think they're having the big one. And we do everything and it's not.
big
We don't make it. And I wonder if it's in the field too.
Uh-huh.
Are you seeing that?
I haven't been running those calls.
We're getting a lot of it. in the hospital.
You've ran one?
No, I
They
mean,
just
I
want to get
ran,
in really quickly.
I ran one that was that, and they had a desperate need to want to use the bathroom. So I don't know if that's a vagal urge to push or something like that, but they wanted to use the restroom.
That was having a massive MI? Yes, I've heard of that. I don't know the pathology of that off the top of my head,
PE, never mind. That was, never mind.
but with coronary, I've heard that too.
Interesting.
Yeah,
Okay.
yeah. That's why I like, who was it that I was talking to? That's how you end up finding a lot of people like on the toilet. The urge to bear down and push is one of those like, signs and symptoms you have before you're gonna, yeah, have the big one or whatever you said. So yeah, there's something to do with bowel movements and coronary. I just don't know exactly what it is.
Why is it easier to diagnose heart problems with women via like doing an echo, right? An echo rather than.
Easier to diagnose heart problems.
Yeah, like instead of a stress test, like a lot of women's heart problems don't show up on a stress test, but they do in an echo.
Honestly, I don't know that
Okay.
answer. I have no idea. I'll be the first to admit if I don't know something.
Yeah.
But I tell you what, that's something that I'm gonna want to Google and figure out. And maybe for our next cardiovascular, I'll have the answer for it.
Yeah.
Or better yet, why don't you research it?
Yeah, I will.
There you go. Cool. So as far as like how they present, we have a pretty good idea. We know that we're going to have that chest pain, shortness of breath, diaphoresis, that, any kind of radiation, that kind of thing. Say we have the patient that's presenting that way, then can I get into my,
I like this one.
It's like tile square.
how do I, can I do that? Cool. Okay. I don't want this on this screen. Can I do this on this screen?
Yeah. I'm gonna pause you guys for just a second. We're gonna switch over to his iPad.
Oh, there we go. Sounded like an alien. Okay. So. Sorry for the technological stuff, guys.
Crazy.
What?
He's got like weeds on his face.
No, okay, cool. So I wanted to go through a couple of scenarios with you guys. And this is why I wanted to switch, that way you guys didn't have them on the screen and cheat. Oh, huh?
Shooter.
Yep. We are, and let's do this as a team, right? So let's all group discussion this. There's no team leads or anything like that. Let's just talk through what our thought process is and what we would want to do for these patients. So we have a 64-year-old male who's got chest pain, shortness of breath, and generalized weakness is what we get from dispatch. We are dispatched to a single-family residence. It's a nice, clean, well-kept home. Our scene is safe. What do you guys want to do when you get in?
Well,
I'm just gonna grab the monitor.
let's do good blood
Full
pressure.
set of
Baseline
vitals.
vitals.
We'll set a vital, after we seem safe, we'll set a vitals.
Okay.
12 lead.
Are you skipping a couple of steps, you think?
Yeah.
You're
What's
walking
going
right in the
on
room
today?
and diving on the patient to take a blood pressure.
What's going on today?
There you go. Yeah, I don't know. I was just sitting in my recliner when all of a sudden my chest started to feel a little weird, and I was having a hard time breathing.
Has this happened before?
No, this has not happened to me before.
What time to start?
About 20 minutes ago,
What were you doing?
I was just sitting in my recliner.
What does it feel like?
It feels like kind of a pressure almost.
Is it painful?
How does he look?
I don't know if it's painful. It's really uncomfortable. You said, how does he look?
John asked, how does he look?
Like shit. He's cool, clammy, and pale.
Radial pulses?
Radial pulses are present and a little thready.
What do you mean by a little?
Thready.
Every other one's ready.
Me, start putting on?
Oh, yeah, because you want to walk in the room and get a general impression looking at your patient, right? Thinking back to EMT school, what is the acronym that we should always go through with all of our patients?
Are they?
OPQRS.
Yes.
Yeah.
Yes,
ABC.
there you go. A, B, C, D, E, right? Depending on whatever.
John says ours radial pulses equal.
On both sides, both arms?
Yeah.
Yes, they are. Good thinking, John. I like
Can we
it.
go through what DE is again?
Disability and E is exposure.
Okay.
So it just depends on.
Expose them. Disability got me once.
Yeah. Yeah, you called, so you're getting naked.
That kid's on the stroller.
I might
Kid was all gawked out
While
anyway.
we're asking these other questions, how long is it ago? I might ask, is there any relevant history, family history that we need to be aware of?
Oh, good. Family history. No, I don't have any family history that I know of. I'm adopted. I don't know.
What's this guy weigh?
Taking medication.
What does he weigh?
Is he a big fat ass? What are we looking at?
He's a big boy. He's probably 250.
That hurts.
You didn't ask how tall he was.
John says, palp his abdomen. Does it change pain or palpate chest for change? do the thing on the torso and
Palpate his abdomen.
feel it, yeah.
It does not change his pain or his discomfort.
All right, I get a blood pressure during this time. What's his blood pressure?
Okay, we are bouncing all over the place.
Ooh.
Okay.
Well, that's what
Wait,
happens when
can
you
I
get
get
after.
Yeah.
a first set of vitals?
No, not yet.
Oh.
So going through and doing our ABCDEs, right? That's how we should systematically approach every patient, even though we're not, going to be doing this on paper for each one. Like you can fly through some of these pretty rapidly. When you first walk into the scene, what does A stand for? Airway. This guy's talking to me, so am I worried about his airway? Probably not. As far as his breathing goes, has anybody asked anything about his breathing?
How many breaths per minute is he doing?
Okay, he's breathing. He's breathing 20 times a minute.
Okay.
Okay.
All right, now I want to check for circulation. What's his pulse?
Okay, his pulse is rapid and thready.
Equal.
Yeah, and equal on both sides. But talking about his
He won't
20
give
on
us
his,
anything else.
Oh,
Thready and equal.
real quick, go back to that 20. Is 20 a normal respiratory?
yeah, it's a little high, but it's not scary. I mean, 12 to 18 would be like normal.
Half of everybody puts 20 on the reports anyway, so I feel like that's pretty normal.
It depends on the
16.
patient.
Every damn time.
Right?
Well,
In general, I will challenge you guys to sit there right now and breathe at 20 times a minute. I bet you'll pass out.
But
So
that's
I-
just 1 minute. We're looking at 1 minute of,
We're
An
talking about,
hour.
we're talking about ventilations. Ventilations are at 20. So if you're at a sustained 20, what I'm trying to get at here is don't just go off the textbook, what's normal. Treat your patient, not the monitor, not the ranges you learned in school. In general, people don't breathe at 20 times a minute. They just don't. So if you're sitting there at sustained 20 ventilations per minute, odds are there's some kind of process underlying that's causing that. So just because you see 20 on the monitor, when you put them on the SpO2 plus wave or whatever registers at 20, don't necessarily think that that's normal, right? You should have some alarm bell that goes off with that, especially if after you've been there for 5-10 minutes, things have calmed down a little bit, that initial like stimulation of lights and sirens and a whole bunch of strangers bursting in their house has gone away. We should see that respiratory rate decline a little bit. And if it's not, then be thinking of what could potentially be causing that. Okay.
Is my patient sitting up in his recliner, or is he like tripod or anything at this time?
He's tripoding.
What's a breathing?
Lung sounds are clear and equal bilaterally. What'd you
Does
say?
he have
That's a
pedal
breathing
edema?
concern.
Pedal edema.
Good answer. That's what I was trying to get to with the big guy.
Or ascites?
I don't think I know.
No, does not have any pedal edema or ascites.
is he feeling that discomfort anywhere else?
Does it radiate? That's a good question.
No, it's not radiating anywhere.
Can I get a blood pressure now?
Sure. So blood pressure is your first set, and I have multiple sets. So depending on what we do with this patient, depending on it changes what's going to happen with it. First blood pressure you get is 110/60.
Can I do,
What's his heart rate?
Heart rate currently is 100.
And his pulse rate?
Pulse ox is currently 96%.
what about poorly?
Has he treated the pain with anything, John says?
No, he has not. He's not
Oh,
taken
since
anything.
he- can we give him?
Rolaids, aspirin?
There you go. I like that. As you walk in the door, do your initial assessment. He says, I'm having chest pain. You should, what I like to do, and I don't know about the rest of you guys, if I'm getting called to a chest pain, short of breath kind of call, put the aspirin in your pocket. That way you have it ready to go when you walk in the house. I don't know if you guys agree with that or not, but put it in your pocket. As soon as I look at him, I'm like, you look like shit, and you tell me your chest hurts, boom. I'm asking you if you have an allergy to aspirin. What are the other questions I want to ask before I give aspirin?
Has he, like he said, has he taken
Erectile
any medications
dysfunction.
or nitro or anything?
That's a nice.
Have you already taken any
Sorry,
aspirin?
what did we say? Is that aspirin?
What?
Have you already taken any aspirin before I got here?
Yeah. Have you taken any aspirin before I got here? If so, how much? Are you allergic to it? And then what's the other big one for aspirin?
How much you take before you show up? Are they still high?
Recent bleeding or GI bleeding? Any history of recent surgery, something like that? If they just had their hip replaced 3 days ago, I maybe want to be a little cautious on giving them aspirin because they'll probably make them bleed. Right?
Will we care if they're like warfarin or anything?
Isn't
No.
that more of a precaution, not necessarily a contraindication?
It depends. If you have a GI bleed, it can be an absolute.
Okay.
So it just kind of depends. So yeah, none of that applies, and you want to give him aspirin? Okay, we give him 325 PO. Cool. All right, what else you want to do?
Do you take nitro?
I do not take nitro.
Have you had this pain before?
I've had chest pain before, but nothing like this. And it's not really, like I said, a pain. It's more of like a discomfort. It's just uncomfortable.
What did the 4-lead show?
4-lead is showing normal sinus.
12.
Oh, so you want to get the 12 lead on scene? How many people want to get the 12 lead sitting in the guy's living room? How many people want to load them up and get it in the bus? Load them up and get him in the bus? Okay, cool. So we're gonna get him up. Are we gonna like walk him out to the stretcher or?
Take the stretcher in.
Yeah.
Put him on the stretcher.
Why do we want to make sure we're not walking that guy?
Oxygen, man.
Bingo. Good.
Orthos?
But. I mean, I might want to like an orthoscopic pressure. You know
No
what I'm
way, look, this guy's fucking sick as hell. He's
Yeah.
tripod, he's fucked up. We gotta get
Yeah.
out of here.
Okay. And you said orthos.
Yeah.
Do you want that too?
I would do it.
Okay.
saying? Yeah,
I
there you go.
didn't
But-
I
write
would take a
those.
pressure on both sides.
I didn't write those down. Pressures are equal on
He's
both sides.
everything they want him to be.
He's not positive for orthos.
We'll say no. I didn't plan on that, so I'll just make that a little
Okay.
bit. So no, not positive for it.
You could trace the shortness of breath if he's tripoding.
Yeah.
Okay, so good. I like that. The next thing that we need to do after we get aspirin on board is what? Oxygen, right? So what are we gonna do for this guy? He's sitting at 96%. Why do I want to give him oxygen?
Because he's having difficulty.
He's having difficulty breathing. So, and he's tripoding. He's showing signs of trying to compensate for whatever's going on. So his body wants more oxygen, right? Ultimately, or he's trying to get rid of CO2, one of the two. Let's give him a little bit of oxygen. What are we going to give him? He's at 96% now.
2 liters nasal.
Sure, right? And we're trying to get to that 90, no more than that 99%. Yeah, we can always back it off if we need to.
15 liters on the
15 liters on our breather.
CPAP.
Only once he loses consciousness.
Reset of vitals,
What?
repeat of vitals.
Okay, so we get another set of vitals. What do you want? You want rectal? He has rectal tone. Is that what you're looking for?
Blood pressure.
Blood pressure this time is 96/60.
Oh,
Okay, surely by this point, we've gotten out to the ambulance.
Start a line.
Okay, so you started a line.
Okay, 12 lead.
Okay,
And we palpated the abdomen. Did we feel anything?
you did not feel anything out of
Any traumas?
bound or out of the norm.
That's a good
If
question.
we start a line, I'm gonna go ahead and do 250 bullets of normal saline.
He's a big dude.
Just because he's got that. Well, he's got 96 over.
Over 60.
Any recent traumas? Anything like this?
No recent traumas. I mean, I stubbed my toe last week, but other
What
than
did
that,
the
we're good.
12 lead show once we got it right?
There you go. 12 lead is showing 1 millimeter of elevation in 2-3 and AVF, with what looks like 1 millimeter of depression in AVL. Can you call a stimulant on that?
Yeah.
Can you?
You could do anything once.
Yes,
You can have-
wouldn't you be able to consider a stimulate since it's 1 millimeter elevation along with reciprocal changes with the depression?
Yep.
But will have to be 2 or more leads.
Yep. It's 2 or more millimeters in 2 or more contiguous leads of elevation. And you need to have reciprocal changes of at least 2 or more, or one. It's 1 of depression. You need to have 1 millimeter of depression, 2 millimeters of elevation, right?
Correct.
Yeah. 1 millimeter of depression in 2 or more contiguous reciprocal leads. So I have 1 millimeter of depression in AVL. So I can't call a STEMI alert on this. Am I just gonna go routine to the hospital? He's not having a STEMI.
No.
We'll call it space.
We're
By the
calling.
by, I'm
we're
gonna
going
let
live,
you make this decision, but you can call a stimulant if you want to. I can't because of my program.
There you go. That's exactly what I would do. I don't know what you guys online think, but I'm gonna call the doc and be like, hey doc, this is what I have. You do with it what you will. Yeah? Agreed? Cool. What's the difference between this guy's 12 lead now and probably the 12 lead that we're gonna take 15 minutes from now? Because let's say we have a long, prolonged transport.
Vastly different.
Yeah. So this guy might be having the whole end STEMI thing, or end STEMI that's progressing to STEMI. If we take another one in 15 minutes, what do you think the ST segment's gonna do? It's gonna continue to elevate. What do you think the reciprocal leads are gonna start to show? More depression theoretically. If you're looking for a 12 lead to confirm your suspicion, give it 5 minutes. It probably will if you're on the right track. Okay. Would you guys online agree with that? Yeah, I'll take your silence as agreement. Okay, sweet. Well, if John agrees, then I'm good.
Everyone agrees.
Yeah, sweet. So what else do you guys want to know? We're in the ambulance now, poof. And let's say that we have a 30-minute transport time.
Second set of vitals.
Second set of vitals. We've already got the second blood pressure. Second blood pressure is 96/60.
SPO2.
SpO2 is now 94%.
And work of breathing, is it?
Work of breathing is still normal, or not normal, still the same. He's wanting to position and tripod and showing signs of wanting to open his airways.
So far, we've given
We
aspirin,
haven't given
oxygen.
that yet.
John
No.
says increase. Well, he's.
Increase O2?
Yes.
Okay, what do you want to increase it to, John?
Four.
4, perfect. Okay, done.
What's his AAO status at this time? Is he a lower rate and everything?
He is,
Is he with us?
very good question. Initially, nobody asked that when we walked in. He was ANO ×3 when we first walked in. He is still ANO ×3.
Is that his baseline?
No, it's not.
Can I get a BGL at this time?
BGL is 108. And did you guys finish going through your OPQRST and sample?
No.
No? What are we missing?
Last time.
He had lunch and dinner.
Does he have any
Medical
allergies?
history?
Allergies, he doesn't have any known allergies. Medical history that we asked for? He is a type 1 diabetic. Okay.
Has he taken all his medications today?
He only takes insulin and he did take that today, yes. So is that painting any more of a picture for the cardiac stuff?
Well, not as far as blood sugar.
What is the one disease that goes hand in hand with acute coronary syndrome? Or ACS in general?
Sclerosis.
That is the
Is he
ACS. Diabetes
Diabetes.
is huge for any
John just
kind of
said-
heart stuff and vasculature. There you go, John, good man. Diabetes is massive, it causes all kinds of endothelial damage to blood vessels and a lot of atherosclerotic plaque buildup and yeah.
How's this pain?
Again, not in any pain. It's like a discomfort.
Hold off.
We wouldn't give- Well, we can't give nitro because it's inferior. But
If I wanted to, let's have a thought experiment on this. We know that I'm probably having an inferior MI, even though we're not calling this the STEMI alert. We're looking at an inferior. We all agree on that? Okay. So if I want to confirm that it's right or left sided, or if I could possibly give nitro, that kind of thing, what could I do to rule in or rule out? What? There you go, coming in clutch. V4R, are we all familiar with what that is?
No.
It is a V4 on the right side of the chest. So where does V4 go?
Mid-clavicular, just below the. Just
So-
below the nipple.
And it's in the what intercostal space?
I can't remember. Fourth.
It's like down to the diaphragm.
It's in the what?
that's what I thought.
It's in the 4th, if I'm not mistaken.
Fourth.
Right?
Depending on where.
Yeah,
the-
it's in the 4th.
Or how saggy the boobs are.
Okay, cool. V4, that's V4. V4R is in the exact same location on the right side of the chest. And so if I put V4 there, what am I now looking at better? My right ventricle, right? Or if I wanted to be really thorough, what else could I do? I could do posterior leads. You guys heard of those? Yeah, like the V 7, 8, 9, 10, 11, 12. Yeah, you can put all those across the back.
How cool.
So do you want to do a V4R? Yeah, V4R shows elevation. Bummer. So what are we not gonna get? Nitro. Good. Cool. What else do you want to do? Or no?
Could you give fentanyl?
How far away are we?
Absolutely.
Yeah.
Well,
He wasn't
that's
complaining of this.
I'm gonna
So
go, just
we
go ahead
still
and call
pick
for
that.
Celeste.
he's not. He's what?
Pick what's still-
He's not it depends on what your definition of hypotensive is. My threshold and what a lot of textbooks will show is 90 is your threshold for hypotensive. Some textbooks, some practitioners are going to have 100 as their threshold. Kind of depends, but personally 90 is my threshold.
But he's close, you don't want to drop
For sure. But what if he is having a right-sided MI? What is his heart dependent on? Preload. So what can I do to bolster or buy me some insurance?
Lucas.
Saline, right?
Which we
So-
started, right?
That's what he said he wanted to do. He wanted to do 250, and he's typically not wrong as far as the amount. I know that you said that he was a big boy, but normally we bolus the body and challenge the heart, right? So a bolus is going to be like that 20 mLs per kg, usually a much higher amount of fluid. Challenge is usually how much? 250, right? So what, based on how he's presenting, and if, has anybody listened to his lungs yet again? Okay, did anybody listen again?
Oh,
Yeah, if you listen to him again, you're going to hear basilar crackles. So what type of shock etiology do you think our patient is in? Hypovolemic? Cardiogenic. Okay, so if he's in cardiogenic shock, and I want to relieve some of that pain with the fentanyl, what can I do to bolster my blood pressure? I don't want to increase my rate or squeeze or give him any kind of, beta 1 drugs.
Can you do a pressor?
I could do a pressor. Is that what should be my first line of defense? What's the first line? Fill the tank.
Yeah.
You always fill the pipes before you clamp down on the pipes, right? And given that his BP is 96/60, I would be, and anybody here, other, practitioners, whatever, if you disagree with me, pipe up. 96/60, if I put a little bit of fluid in the tank and I get you up over 100, I'm just fine getting fentanyl. Anybody disagree? No. Perfect. Okay. So do you want to give him fentanyl?
You wait.
How much you want to give him?
185.
you said he's big. So let's go ahead.
Let's say that he's 250 pounds. So,
Ooh, I was gonna say 50.
Yeah.
You'll know better.
okay. So you want to give 75?
I'd give it slow.
Okay. How slow?
Slow.
Okay. So we give 75 mics of fentanyl. He gets a little bit more loopy, and he says that his chest is not starting to feel as uncomfortable.
How's this breathing effort at this point?
Breathing is starting to get a little bit worse. He's now sitting at 93 on the 4 liters that you upped it to.
Okay.
So he was at 94
Rate,
when he upped it to 4. Now we're at 93, still at 4.
rate, depth, quality,
His respiratory rate is now at 30.
with the fentanyl on board?
Hmm?
With the fentanyl on board?
Yep.
Out of him.
You want to give Ativan?
All of them.
Are you being serious?
No.
Oh, I was like, no. Why are we giving Ativan?
John says non-rebreather at 15 liters and Adrian says duo neb, question mark.
Duoneb. Why would you want to give it Duoneb? Does it?
Albuterol, bro.
Oh, I thought you said dual net though.
Yeah.
That's both.
Yeah,
And
yeah.
albuterol.
Albuterol and Atrovent is a Duoneb. Are either one of those a steroid?
Albuterol is one.
No.
Neither one of those is a steroid. Albuterol is a sympathomimetic, and Atrovent is a parasympatholytic.
Right. Adrian says dry out the fluid in the lungs.
What?
I appreciate the thought process, but that would not be the best way to do that. What's a better thing to do for cardiogenic shock type patients, CHF type etiologies? Lasix is something that you could do, a little bit more old school. CPAP and nitro are God's gift to any kind of cardiac or cardiac asthma, congestive heart failure, that kind of thing.
That way we concentrate.
Yeah, we
Draw
determined that we're not
faster.
going to give nitro, absolutely. But is there anything stopping us from putting him on CPAP? He's short of breath. He's continuing to trend towards hypoxia despite increasing his oxygenation. So I don't know. You guys would you try CPAP? Push some of that fluid back out of the lungs.
But he said he's altered.
There you go. He's ANO times 3.
Can he-
But what's
Can he
the?
follow commands?
There you go.
Can he breathe on his own and can he swallow?
Yes, he could do all of those things. He just doesn't quite know like where he is. Or
if we're like circling the drain really quickly, can we just pull out the bag and start?
Bam, there you go.
BBMing into the valve?
See, this is the cool thing about this and having a group discussion is that there's so many different options and none of us are more wrong or right. It's all just a different way of how we would want to go about things. So I like that. We're getting closer to the hospital. You want to retrend his vitals?
Yeah, sure.
Yeah.
Okay. So he's 92/60 on his BP, 100 on pulse rate. Respirations are 35. Skin is cool and pale and diaphoretic. His temp. Huh?
I put the pads,
You want to put pads on him?
just in case.
Yeah, I like that. Okay. So you put the pads on him. He gets concerned. He's like, "Why are you putting this on my chest? Is something wrong?" No, sir, not at all. His lungs. Did we put him on CPAP or no?
Yeah, let's do it.
We did.
Yeah, let's do it.
Okay, then now his lung sounds are normal. So we had him on CPAP.
Let's go ahead and shock him at 200 joules.
Let's not say we did.
Just kidding, just kidding.
Yeah, cool. So you do
He's fine.
you do a repeat 12 lead. You see massive elevation in 2-3 in ABF. You have reciprocal changes in 1 in ABL. Now, do you want to call the hospital back? Hey doc, this would have had change.
Oh, we're already there. They're pulling in.
We're close, yeah. Here's your stomach. We just hand them off real quick. Depending on where you were, yeah, you probably want to call back and give them an update, right? Activate that. Cool. Anything else that we want to do to treat this guy?
Because
Okay.
we agreed for standardized testing, we agreed went into cardiogenic shock, who will treat for shock.
Okay, cool. So what's the BLS, standard for treating shock?
Yeah, basically just keep his body core temperature. What is his temperature? We never asked.
I said it.
Oh, is it? Okay, yeah.
Temperature is normal.
Well, we got, we'll keep him comfortable.
So yeah, it's gonna keep him warm.
And we'll run a
Supine.
position, we'll also want a submission semi-fowler because he's got CPAP on.
There we go. That's where you would
We wanna
change it.
set him up.
Normally it's supine for shock, right?
Yeah.
So we're not gonna do
But if you
supine.
bring the legs up and the body, you just funnel it down.
Okay. What?
Don't.
To keep the blood, oh wait, never mind, you don't want to bleed out.
For pelvic
just
fractures,
kidding.
you put them in a V.
Nice.
Sorry.
We only hire the best at Morgan County. Bleeding edge medicine shit. You heard it here first. Put your patients with pelvic fractures in a V.
It's revolutionary.
Yep, really is. So what are we thinking the overall pathology of this patient is? What's wrong with
CHF.
it? CHF?
What? Yeah, I mean, he's got fluid into his lungs, right?
But is
So-
that chronic heart failure or congestive
No,
heart
I
failure?
think this is acute heart failure based off of the inferior ischemia that's causing the right-sided heart failure. So he's decreasing his preload and he's getting it back up into the pulmonary.
And I would say, it's
Venous
chronic.
system.
If he's been diabetic, then sure, this has probably been going on for some time. So I don't know if you want to call it acute or chronic, but
If he's
Well,
having
how
an
quickly
MI
it's
though,
progressing.
and you start having tissue ischemia on the right side of the heart.
Yeah.
Right, like. are you
So
gonna
what's the
have
most
right-sided
common
heart
cause, or how do we back up fluid into the lungs? What's wrong with the heart in order for you to back up fluid into the lungs?
failure? In order to have left-sided heart or right-sided heart failure. Left-sided?
Not have to. The
You
most
don't have
common
to.
It
cause.
would be left-sided heart failure.
What?
Adrian said left-sided heart failure.
Yeah, in order for fluid to back up into the lungs, you need to be having dysfunction of the left ventricle, right?
Yes.
Because that diastolic pressure in the left ventricle ends up being higher. So the pressure in the pulmonary vein is not enough to overcome the pressure that's in the lungs still, or does that for me? I can't really, I butchered that, but the left heart is not functioning well enough to get the fluid out fast enough to stop it from backing up into the lungs. So you end up with the crackles and the pulmonary edema, right? With right-sided heart failure, do you get that? No. If it's right-sided heart failure that's not doing its job.
Yes.
Legs.
Yeah, you usually see it in the legs, right? Yeah, or you can also see JVD in some cases, that kind of thing.
Like we're doing in this patient.
Didn't say should be.
Yeah, did you
No,
say,
no, no.
did you say anything about edema?
No.
How about some, oh,
Just basilar
No, the
crackles.
fluid though.
what's this, what's the sputum look like?
Sputum is clear, normal. That's the textbook, the pink frothy type thing, but it doesn't always have to present that way. Remember, our patients' bodies don't read our textbooks.
So you're going with acute coronary syndrome.
And he's right, but you want to think about the etiology, right? So he's got massive elevation in 2-3 and AVF, right? But he's got crackles in his lungs. So we're showing with our V4R that he's having a right-sided MI, yeah? But we're showing through his symptomology that he is exhibiting pulmonary edema. So what kind of MI do you think this guy is having?
All of them.
A massive one, right? His left ventricle is not able to do the job properly, so it's backing fluid into the lungs. And we know from looking at the 12 lead that his whole right side is affected as well. So overall, this guy is having a really, really bad day, right? So this is where you tie in your 12 lead with how the patient's presenting, knowing the anatomy and the physiology of when things go wrong, when things go bump in the night, what's actually going on, helps you to paint a more clear clinical picture. And then you can treat it more appropriately. Cool?
Yeah, cool.
Okay. You guys want to do one more?
Sure.
Okay.
Well, a couple of them. I know. I'll go to the lower right school right now.
Huh?
Sorry.
When did we start? Six.
Just a little watch pocket.
Oh, we can end it here.
Wherever, it's up to these guys, whatever you guys want to do.
If you guys want to do one more, it's up to everybody here in class as well as everybody on Zoom if you wanted to do another scenario. Yay or nay?
Let's do it. Sure.
I got a yay here. If anybody wants to drop out, you've gotten 2 hours worth of CE credits already. Okay. So we're having some people efficient.
Great.
Thank you.
Thanks, Mark.
All right, cool. So we'll do one more for those of you that want to do it. So we're dispatched to a nursing home for a 72-year-old male complaining of chest pain.
Okay, seems safe to be aside.
Nice.
It's kind of safe. It's a nursing home that
You know what?
there's
Fair.
one lone light bulb swinging from the ceiling and it's dark
Is that
and
a ghost?
janky. Yeah,
I'm not going in.
yeah. Everything's wet and smells like C. diff and GI bleed.
Oh, so
Is our patient
Yeah.
tracking us as we walk in?
Yeah, what's he look like?
As we walk in, patient is tracking you, is able to respond appropriately.
All right. So.
Oh, and he's sitting up in bed, holding his chest.
how's he presenting?
What's he look like? Skin. What does he look like? His skin looks warm, pink and dry.
Hey,
Go ahead.
He's ANO times 3. He's just not exactly sure where he is.
baseline's 4 then.
According to the nurse, she's not exactly sure. She's not. This
She
is
just got
normally
off shift.
his patient. She just got off shift. Yeah,
As I introduced myself, I heard it was radial pulse. Didn't have a radial pulse.
perfect. I love that. Did everybody hear what he said? As I'm walking in and introducing myself, I'm checking a radial pulse. That's definitely something that, in my opinion, everybody should be doing on a patient as soon as you walk in the room. Would everybody else agree? Yeah. Walk in, immediately break that contact, feel the pulse. You're getting so much information from them right off the bat. I love that. Okay, cool. So you feel the pulse. It is kind of quick, but it is bounding.
Breath sounds and rate.
Breath sounds are clear and equal bilaterally.
At a rate of.
You break it, you bought it, bud.
You know, I can't afford this.
Respirations are 18.
And then go to abdomen.
Abdomen is soft, non-tender.
Vital.
Any edema anywhere?
Huh?
Any edema?
Not that you see, no.
All right, ask him when this was going to go to USG. So what was the onset?
It was sudden, woke up with it and it's 9:30 in the morning. So not too long ago.
What's his pain like?
He's rating it at a 9 on severity. And it's
Is it pinpoint? Or diffuse?
it's really, really dull, like a pressure, like an elephant sitting on his chest. It's more of like a pressure force type of a feeling.
Adrian says 324 of aspirin, and John asks history of DVTs or recent surgery.
Okay, cool. Everybody want to give him aspirin?
I'm okay with it.
Is he allergic? Nope, good question. He's not allergic to aspirin. So we give him 325 of aspirin. And then he asked about recent surgeries. No recent surgeries or DVTs. No,
Haven't taken any aspirin today. Is that part of his med?
he has not.
Any
On daily
shortness of
medication?
breath, nausea, vomiting, diarrhea, that
No.
numbness, tingling.
Mm-mm.
Well, because of his mental status, times 3, at this point in time, I'd like to get a BGL and also get a blood pressure as I'm working on
Perfect. BGL is 110.
Okay.
Blood pressure is 162 over 84.
SpO2.
SpO2 is 98% on room air.
98.
98.
Pupils,
Pupils are equal and reactive.
smiles, talks to us normally, not slur or anything.
You go through a full neurological on him, and it's totally negative.
Breaths.
Clear and equal bilaterally.
Just chest pain. Did he fall?
Good question. No, he has not fallen. He hasn't fallen in a couple of days.
Do you take all of his prescribed meds?
What are his prescribed meds?
Yeah, what are his?
Yes, and they are Zantac, which is what?
So allergy.
Zantac is a stomach thing, right?
Oh.
Yeah. Good. Yeah. I think it's a proton pump inhibitor.
Antacid.
Yeah. And then he also takes nitro. He has nitro prescribed.
Has he taken that yet? Do you know?
He has
How long ago?
about 20 minutes ago. He did one of nitro. He is also on Lasix and potassium.
Make it any better?
Any relief?
No, did not really.
Does he have a heart condition?
His doctor said something about he has some heart condition, rhymes with vagina. Can't remember exactly what it is.
Is he paced?
Huh?
Does he have a pacemaker?
He does not have a pacemaker.
All right, but he does use deflation, so he does have that.
He takes Lasix, so he has
Is
diabetes.
that what you said?
Yeah, he takes Lasix,
Okay.
so he has diabetes.
Oh. I thought it was, in Salt Paul's water. I thought it was from-
Lasix is a diuretic. We're trying to drain fluid off you with Lasix. That's why he's also on the potassium,
But he doesn't have any edema.
But
because Lasix is a loop diuretic.
Yeah, but
So you end up,
Oh, where you pass that down?
No edema, lungs are clear.
no edema, lungs are clear. Anybody online want to do anything? Yeah, okay, so you do it.
Transfer to cot, increase oxygen to 4 liters to bus.
Cool, I like that. So
Oh, I didn't
we're
ask this.
I got it.
SpO2 is 98%. So everybody agree, get him on the cot, get him out to the bus? Or are we gonna do the 12 lead on scene?
No, let's
I'm
go.
going to do the 12 lead in the back.
Do it on the bus?
Usually for any chest pain, I would do 4 lead on scene.
You wanna do the 4 lead on, what do you guys think? What do you wanna do?
Force them on. Yeah, more description.
What does John wanna do? John's a patriarch.
Or LD.
4 LD. Oh, do it on scene or do it in the bus?
4 lead.
Yeah.
I swear I was like, what is he saying? I was like, what is 4 LD? And then 12 lead in bus.
Cool, okay, so 4 lead on scene. You do the 4 lead on scene and it shows normal signs.
Sorry, John.
Okay, in the ambulance.
Okay, so now we're magically in the ambulance. Poof. Okay, we do the 12 lead in the ambulance.
Yeah, key in the line. Start.
Okay. It looks like you see multiple leads that have inverted T waves, as well as left axis deviation.
What do the inverted T waves mean?
Anybody else want to take a stab at that?
Beginning.
Beginning levels of ischemia, right?
IV, nitro,
IV nitro.
per John.
I like that. Okay. So as far as the inverted T waves, the stages of ischemia, typically what you're going to see first is you're going to see inverted T's, possibly even a little bit of PR depression. And then you're gonna have that rebound ST elevation to the point if it's real bad, that you see those like tombstone T's where the R like bleeds over into the T wave. Then eventually, as that tissue is all died and gone to heaven, the ST segment will lower again, and then eventually you'll develop that pathologic Q wave at
Okay.
the beginning. So that's what the whole progression of ischemia to infarction to necrosis looks like. Cool.
Thank you.
No problem. So yeah, we want to do nitro. So what do we want to ask this guy if we're going to give him more nitro?
ED pills.
He has not taken any ED pills recently.
In the last 48 hours?
No,
Blood pressure still 164.
162 over 84.
You only take the one dose.
He only took the one dose because usually that one dose relieves the pain. So we give him another 0.4 sublingual, and then we got an IV. Are we just gonna do like a 20 gauge in the hand on this guy, or what are we gonna do for IVs?
EJ.
Michael can't get anything past a 22, so.
Oh.
Not all the way true, he said.
I miss 18s all the time.
Okay. So, but in a perfect world, what kind of access do we want to get on this guy? AC? Huh? We want to get two of them. I like two. Where historically is the one site that we want to avoid giving IVs to chest pain patients? What? Forehead. So what does the cath lab usually want to leave open?
I don't know.
They usually want to have the right AC available because they are not taken up because they usually want to thread through the radial arteries, I believe.
Wild.
Yeah.
So you want,
So historically, the cath labs say to not do the right. Right arm. Everybody else heard of that, or maybe that's just an old wives' tale that I learned when I was going through school.
Yeah.
that's
the most open walkway.
Yeah. They ask that you avoid the right side. Anyways,
So are we getting 2 lanes then?
I would.
But not on the right side?
I personally would be like, screw it.
Oh,
If I need access, I need access, and they can sort that out.
why are we doing 2 IVs on this one and we only did 1 on the last one?
Well, we didn't really talk about it on the last one,
Okay.
but on this one, I would want to do 2 for a couple of reasons. Why would we want to do 2 for a sick cardiac patient? Rapid bolus, medication administration, plus what are they going to probably want to do in the hospital? Contrast?
Yeah.
Contrast, and usually you can't give contrast through a line that you've given anything else, right? So having that access kind of sets up the hospital.
But if we're pushing drugs through it, then that they can't use it anymore.
Odds are what I'm probably gonna do is have the 2 access points so that I have 2 if I need them,
Mhm.
but more likely than not, I'm gonna set up that one on the right side to just be used by the hospital. I'm gonna use the left side for whatever I need, because odds are I'm probably not gonna need to slam in, 2 liters of fluid on some guy, you know what I mean, simultaneously. So I'm getting 2 to set up, give the layup to the hospital so that it's easier for them.
Okay.
Cool. Anybody disagree with that, or you guys like that?
So in our last guy, we would have done 2 lines as well, right?
On pretty much any serious patient, I would like to do 2 lines, because there's lots of different medications that you can't put through the same line. They could, there's all kinds of issues, precipitation of the drugs, you don't want to create, what the hell? I can't remember. So what is it, calcium and bicarb? One of the ones that does that? Precipitates calcium and bicarb precipitate in the line?
Yes.
Yeah, so stuff like that, drugs that can't. Calcium and bicarb, yeah.
Well, it's the precipitate.
Yeah, it's like turns to
Calcium
chalk. So it's for reasons like that, always get the 2 lines.
Would you draw bloods too?
Yeah,
And I feel ashy.
yeah, I would draw bloods for sure. Why would we want to draw bloods on a cardiac patient?
So that we can test, like,
What's
make
the,
it quicker for them to see everything, and then if we're altering anything. Yeah, but then will it change
troponin?
throughout the course of driving to the hospital?
The
Their levels?
troponin. Well, there's 2 different
No.
types. We got troponin T and troponin I. Then we also have the creatinine kinase myoglobin, and what's the other one? That's a part of the cardiac enzyme panel. There's one more. I can't remember. But they're incredibly sensitive. What?
Oh, there was just, it said you were about to raise your hand on the screen and I was like, did anyone else see that?
It recognizes.
That you're raising your hand. Yeah, see, okay,
Oh, what
sorry.
does that do? I raise my hand.
It
Your
just
hand?
says that-
Oh, okay, cool. Can I put my
Sorry.
hand down? No. Anyways,
Sorry, ADD.
so yeah, drawing bloods, it just speeds up the process for the hospital.
Yeah, okay. Sorry.
Okay, so where were we? We were in the hospital, we did a 12 lead. Right?
The ambulance, we did.
We're not in the hospital, we're in the ambulance.
Yeah, we gave nitro.
Gave nitro.
What's Blood pressure after nitro.
Blood pressure after nitro is 156/86.
156/86.
So
What's his pulse now?
Pulse is 88.
And what's the stats?
Sats are 97%.
Wait, give another nitro? After 5 minutes?
What do you want to ask this guy before you give him another nitro?
How's this?
Yeah, how's your pain?
Yeah.
Right? I don't need to throw all the nitro at him if one more, fixed it. He says that the pain's better after the one nitro. Or the second, I guess, the one that we gave him, apart from the one that he took.
You said lung sounds are clear.
Lung sounds are clear and equal bilaterally? Okay, we repeat the 12 lead. What did we see before in the 12 lead? Okay. Okay, so I still see T-wave inversion, maybe a little bit of ST depression. That's about it.
So wait, hasn't that improved?
Well,
From the
for
first
him, for how, when he says he's feeling, it feels better, but the 12 lead is still showing some stuff,
Oh,
which could make sense, right? It's not gonna automatically fix whatever his problems are, especially if nitro is not usually, it's not designed to be a reperfusion agent, it's just meant to get rid of the pain.
Mhm.
So let's say that we're, coming up on the hospital. Anything else we want to do for this guy?
I mean, we put him on oxygen, right, anyway, right?
Yeah, John wanted to put him on oxygen. He's at 97%. Anything else? So what do you think's wrong with this guy? Unstable angina. Are we all familiar with that?
no.
Yes. No?
Do a refresher on that, yeah.
So what is angina?
It's like similar to like an acute coronary syndrome, but
It's
basically a heart pain.
it's basically the heart version of a TIA. You know what a TIA is in relation to stroke?
Mhm.
It's like a little mini stroke that auto resolves and that kind of thing.
I think Dan has his hand raised. I don't know if that's on purpose or not.
Dan, do you have a question, bud?
No, that's not Dan.
Who is that?
That's, it says your hand is raised.
Oh, this is Dan.
Oh, never mind, Dan.
It's on his.
Good thing you don't have a question. I didn't want to answer it anyways. What was I saying? Oh, so angina is the equivalent for the heart. So you have usually due to like that picture that we're looking at, some kind of atherosclerosis that's building up, narrowing the lumen of the coronary artery. You don't have any problems with flow or perfusion or whatever to cause any kind of ischemia. But what ends up happening is when you overuse the heart and you require more oxygen demand than what the lack of blood flow is able to get to that area, then you end up developing symptoms. Like the guy that's shoveling snow, his chest starts to hurt, that kind of thing. The difference between stable and unstable angina is stable angina, that pain is usually resolved with rest. So I'm shoveling snow, my chest starts to hurt, I sit down, 10, 15 minutes goes by, my chest doesn't hurt anymore, and I'm good to go. It becomes unstable when rest no longer relieves it, or if normally one dose of nitro, let's say nitro, one dose of nitro takes care of it, fixes the problem. Now, you've taken 2 or 3 and it still, hasn't resolved. Then that's when it becomes unstable, right? When something's
Meaning that
changed,
you're-
basically.
So the unstable, would that put you closer to having an MI?
Absolutely. Yeah. If somebody has a stable or unstable angina, they're basically just a time bomb waiting to happen for the most part. Because that plaque hasn't ruptured yet.
Mhm.
What all does it take for that plaque to rupture? Not much, right? You I don't know, wake up on the wrong side of the bed, you sneeze too hard, you strain having a bowel movement, you're sitting on the couch and it just happens to be your time. It doesn't, those can rupture for a multitude of reasons.
And you said if it ruptures, you can see that on the 12 lead, kind of?
When it becomes the MI.
Oh, gotcha.
Yeah.
Okay.
So on the 12 lead, we only saw the PR depression, ST inversion, or not ST inversion, ST depression, fucking having a stroke, pardon my French. ST depression and T wave inversion, right? Those are the earliest signs of ischemia usually. And that makes sense. He's not having a full MI, he's just exceeding the oxygen demand of what the heart, he's not able to meet the oxygen demand of the heart. So that's why he's showing those changes on the 12 lead. Makes sense? He's not having an MI, he's writing myocardial checks that his blood flow can't cash.
Yeah.
Cool.
Mhm.
All right. So we're thinking angina on this guy. We did everything that we should to treat him. Anything that we would have done different? No?
I mean, basically, you only rest in nitro usually relieves the symptoms of angina, so.
Yeah, we took him to the hospital. He's gotten worse, right? We know that he's unstable because normally he takes a nitro, rests, whatever gets better. He's taken one already and it didn't do anything. We had to give him 2 in order for it to get a little bit better. So he's definitely in that unstable area. They're probably still gonna end up taking this guy to the cath lab, I would imagine.
I think it would surprise me with this guy. He's just hypothetical. If he's on Lasix, it seems like he may be dehydrated. Probably his blood pressure could be a little bit lower on top of all this, you know. But
He's on Lasix.
well, I mean, he'll be dehydrated. Won't he? I mean, water follows salt, right? It's basically makes you pee out all your liquids and everything, doesn't it?
Well, that's what Lasix is. It's diuretic. Yeah, it's trying to off extra fluid.
So I'm just being hypothetical. I'm just playing devil's advocate here. It just seems like he present with different things.
It kind of depends on what he takes in for drinking, what his dose of Lasix is. I would say that there's a lot of stuff, but what can we do to check for hydration
Well, you
status?
said he was 1 pink and dry.
Skin
so-
turgor.
Skin turgor, very good.
Yeah, but you already said
And even so, if he is, if you're concerned about that, what can you do?
well, you put him on fluids.
There you go. Cool. Well, that's about everything that I have for you guys. I know it was a little bit of a shit show. This is my first time ever putting together any kind of content, and you know, I was kind of making this up as I went along, so to speak. So I hope that you guys enjoyed it. If you have any other questions or anything that I can do for you, please let me know. But as of now, I think you guys are released. You got 2.5 hours of CEs.
Thank you.
Thank you, sir.
Later, John. I'm back, by the way.
Love you, John.
Yeah, I'm back. I'll be with you in the next call.
You're gonna have to put up with this shit until I get back.
I'm COVID free.
Thanks for your time.
Stupid story I want to tell you because I didn't want to do it in front of your presentation. So we'll be ready.
Thank you guys for joining us tonight. I'll get you your certificates emailed to you.
And
And if you have any questions, just reach out to us, okay? Have a good night.
Yeah.
Thanks, Travis.
This will also be, it is recorded, so it'll also be posted on our Google Drive account if you guys want access to it.
And it was happening to like all this, we're all getting like these flashes, we call them stingers, but really it was just probably us getting freaking brain bleeds.
Jesus, Mike.